6th edition of the LA Shoulder Podcast. Welcome back. Today's guest, somebody whose name is synonymous with surgical excellence in both hip and shoulder. Both the shoulder worlds. He's a pioneer, an innovator, and a true educator in the field of orthopedic surgery, Dr. Carlos Guanche.
Thank you for having me, Michael.
There's more.
Golf clap.
Let me introduce
But we're not
you.
done.
We're not done. No, there's a lot more. He's internationally recognized minimally invasive approaches to complex procedures like hip labral repairs, FAI, femoral acetabular impingement, reverse total shoulder arthroplasty. In fact, he was one of the first surgeons in the U.S. to perform the reverse. Is that right?
Yeah.
What year was that?
2000 or one or two?
2004, actually.
Yeah.
2004 was,
Yeah. It was my last year in Minnesota. And
You did in Minnesota?
Yeah, I did. Well, I knew it was coming because I was. They had approached me to be part of the FDA trial, and so I saved a list of like 30 patients, and so all of a sudden, when they said go, we did like 30 reverse total shoulders.
You
in
say
Minnesota.
go, let's see
and they
how
were
we
like,
go.
What is this reverse thing? Like, what are you doing?
Yeah,
You know,
that
it's
wasn't
pretty
even.
crazy.
It was a backward shoulder at the time.
Oh yeah, they were crazy.
So Dr. Guanche started his journey at the University of Miami,
Yep.
and that's where you graduated magna cum laude from the Leonard Miller School of Medicine. From there, he trained in orthopedic surgery at the prestigious Albert Einstein Medical Center in Philadelphia. That's in Philly, right? Not New York. It's Philly.
Yeah.
He then completed a sports medicine shoulder fellowship at Minneapolis Sports Medicine Center, where he learned more complex arthroscopic and reconstructive techniques. He's held faculty positions at LSU, University of Minnesota. He's worked as a team physician for Division I college programs, pro teams, and hundreds of fellows and residents you've trained. He's now based in Southern California. You were at SCOE before
for
Cedars now.
20 years, yep.
At Cedars, practicing in Tarzana, and now coming to LA as well.
Yep.
Perfect setting for the LA Shoulder Podcast.
I hope so.
So he continues to innovate, teach, and operate at the highest level. Welcome to the podcast, Carlos.
Thank you. Thanks so much for having me.
Yeah.
I'm
and
excited.
My second guest, he's kind of a side guest, Pat Boss. Pat Boss is a surgical device rep for Golden State Orthopedics.
Yes, sir.
And how long have you known Carlos?
I have had the privilege of knowing Carlos since he came to California.
20 years.
20 plus years. In 2003. I got in the industry in 2003 when I was hired, and 2004 we got the reverse from Tournier. And
So you guys have worked together for 20 years?
The whole time.
the whole entire time.
How long have you been friends?
It's been a
20
lot of
years
hard work of polishing wheels. No, I'm
23?
kidding. Totally kidding. Yes. He's for on a personal level, as a device rep, he has certainly helped me elevate my game and exposed me. Malcolm Gladwell writes about these outliers, and certainly Carlos has been one of those tipping point and models in my career as an outlier to help me be better in shoulder arthroplasty and to service him and other surgeons in the industry.
Sounds like more than just a colleague. Sounds like a close friend.
Sure. Mentor, father figure. Yeah, it's you get very few of these people in your life that help young men, right? No matter what their careers, we all get inspired by people. It's usually never our parents, it's other folks. And Carlos, for me, has been one of those men who have certainly inspired me and helped me. You come to Forks and Roads, and helps a good man be better.
How did you guys first meet? Was it just by happenstance? Was
Yeah,
it in the
I
OR,
was
or?
when I came to LA.
You said
I was
California.
When I came to LA from Minnesota, I was Tournier. I was using Tournier, and he was the rep. He and this other guy, Tony.
Yep.
And so I just started working with Patrick, and right away I knew he's so smart and so involved.
He looks like he knows what he's going to talk about, right?
Yeah,
He was big, thick glasses.
and he's just
Should
prepared.
listen to him.
I mean, how important is that for us to have all the equipment? And so from day one, I was kind of like in love with Patrick and his service. And so then he and I have actually migrated to 5 different companies? I don't even know.
Yeah, well,
I just kind of followed him.
Migrated through. Meaning he changes.
He
and you
switched
follow.
companies, and I followed him because he believed in the product, and I believed in his representation, and so I, switched probably at least 3 times.
I was going to say
times.
it is 3 times. It was Tournier for almost 13 years, and then a short stint with Integra, right?
And then DePuy.
Growing pains, and now with DePuy.
What type of products? Shoulder,
All
everything?
shoulder.
Yeah, Pat, you're a specialist at shoulder, right?
Well,
Shoulder
yes,
arthroplasty.
I sold hip and knee, and I gravitated toward hand and upper extremity. So again, one of these weird outlier effects. When I first got into the business, we had Hand Innovations, which literally had just launched.
They make a specialty plate.
Well, they made a
fractures.
volar plate,
Yeah,
and so
volar
back in the
plate,
day,
locking distal
there were no volar plates,
periarticular plate.
right? And at the same time, the local distributor picked up Tournier from the Arthrex distributor. Right? And so these events happened to where I was selling two things that were really hard and were like pivotal products in the industry. I even tell a story where like I had hand guys throwing me out of their office because they were like, "Hey son, why would I go volar to do a dorsal comminuted fracture?" So the shortest answer is learning through Carlos and his colleagues. I became an extremity expert. So I also learned that if we can depend on one guy giving us service, that's where I started diversifying my portfolio and honing my business acumen to service. I could do anchors, I could do ACLs, everything top to bottom.
Yeah.
So
I even convinced Arthrex to
That's
hire
a great
him.
story. You should. Well, I don't know if it's.
he was a young burgeoning.
Yeah,
rep.
he was. I think this was like 3 or 4 years into your experience.
Yes.
And I was so frustrated because I had been a big Arthrex product guy coming from Minnesota, and their representation locally at the time was just horrible. They hired all these young kids, just threw them to the wolves, had no clue. And so I finally called the owner of Arthrex. I called him and said, "You got to hire this guy.
We need better
I don't
standards."
care. He's a Tournier rep. I know there's some competing products, but I don't give a crap. I really want this guy." And so he hired.
Well, the story is actually a little bit better. We're at Anna out in Palm Springs.
Oh, yeah.
Right? And so he texts me, and we had like the trio phones, right?
Yeah.
He texts me, and he's like, "Hey, come over and have a drink with me." So I come over there. I meet Reinhold. Realize, again, it's like meeting like Jesus.
He's the owner, CEO.
Yeah.
Arthrex.
Right?
Arthrex, yeah.
Really down-to-earth guy. And he's like, so...
Arthrex is Reinhold, right?
Yes,
Reinhold
exactly.
Oh, yeah.
Right, yeah.
He's on the Forbes 500 list.
Yeah,
Yeah,
right.
I've met with him.
He was never 11 a couple years,
Yeah.
3 or 4 years ago. Yeah. So anyway, tell me about yourself. Where are you from, kid? Short story. He's like, wrote down the number on the back of his card. Said, call this guy Monday.
You had gray hair at the time? He called you kid.
Well,
or is it still gray?
No.
Or
You know
white?
what?
No, he was dark hair.
He was dark back
I was
then?
much
He was a
darker.
good-looking
He was a
guy
kid,
back
huh?
then.
Yeah.
Still is. Handsome old man.
Right. So, but I had been going great through high school, so I looked more like Carlos back then. And I was the only rep in the country that carried Tournier full time and the Arthrex bag within the 101.
Yeah.
And it made me. What I have learned through Carlos and other great men that I've worked around is, if I can think like you, right, and bring you something as good, if not better, and problem solve on the fly. I have this weird brain. I joke like I'm Emmett from the Lego movie, right? It's like so empty, but I see things in this weird space.
Maybe you need that space in there so you can consolidate
Exactly.
ideas.
Right. And so it just, so I've carried biologics. I was number one biologic rep. I was number one Arthrex rep. And I just gravitated to the hard stuff. And
Well, we've talked about that, kind of that drive, that you've kind of exhibited in terms of like showing up. And, we do that just regularly. We show up to work and
Sure.
we operate and we have our patients. And, to have somebody that understands that to a certain extent, like you show up for me, I'm showing up for my patients. We're all showing up for the whole system and, getting things
we're all on the
moving
same
and
team.
All on the same team for
Yeah.
sure.
It's a team approach. I think your bicycling probably plays into it a little bit too.
Yeah. The grind. Yeah. Certainly.
Yeah. Pat told me he raced bikes. And I was like, wow, that is so cool. This guy races motorcycles.
Yeah.
This guy is way more badass than he looks. And then it turns out he races bicycles.
Bicycles.
And I was like, I ride a motorcycle too. I have a street bike. I ride
Yeah.
dirt bikes. I used to do jumps. I don't do jumps anymore. He's like, bicycle.
right.
But really
different.
fast. It's hectic. It's crazy. It's racing.
Oh, yeah.
And it is. It's racing. I mean, you've won state championships racing bicycles, right? Are you
Sure.
current or active state champion?
No.
Prior state champion.
Prior. If you were to count the past 10 years, I
It
have
goes
won.
with Golden State. I mean,
yeah.
Golden State makes sense.
But hey,
You're their poster boy.
I need
Yeah.
somebody needs to
You
call
need
my
a logo.
boss. Yeah, I need a
Where's your
sponsorship
agent?
here. Right. Out of the past 10 years, I've got 6 championships in multiple disciplines.
6 and 10.
6 championships out of probably the past decade.
Woo, that's
So,
impressive.
Nice.
For
pretty
3
good.
different, time trial, road.
Are you in any kind of Hall of Fame in terms of?
No. I have like.
And this is amateur.
Yeah,
Amateur racing.
Yeah. Well,
Yeah.
this past 10 years has been masters racing.
Masters.
Consider it like golf, right?
Have you raced pro level?
I've raced pro level, through the mid 90s, early 2000s. I lived in Vegas as a pro because it was a cheap place to live, and originally from Chicago, it's terrible to train in the winter, right? It's indoors. We didn't have the training techniques, the equipment, the nutrition acumen, all that stuff. So
Did you ever do doping?
I
Did you have to dope?
well, it's funny. It's funny you say that.
Only if you want to win.
Yeah.
Well,
you won. So
shortest story is I had an opportunity to go over to Europe to do 6-day racing with who are now famous racers that Lance and I are the same age. I raced against him pre-cancer, post-cancer. So short answer is I couldn't afford the money to dope. That's why I could never go pro in Europe.
Did you take creatine?
I did. You know what's funny? I did 20 years ago. Was taking creatine. There's a
Been around
balance.
a long time.
Yeah. There's great studies now. I mean, look at the studies that have come out the past 20 years.
The most studied supplement is creatine
Yeah.
for performance.
Yeah,
Well,
there's no doubt you should use it.
Yeah,
You know.
I agree.
Well, there's
I feel smarter when I take creatine.
Yeah.
It does. It has, there's a neurological.
Well,
There's
a
a
great-
huge,
I
huge
feel,
benefits
I feel a little
for
sharper.
muscles.
I take it
tone.
before the podcast for sure.
Yeah.
Brought to you by creatine.
Right. Are you taking it earlier or through a straw?
I take XR.
I'm just kidding.
No, I take XR.
it's
XR is not a sponsor, but hopefully soon to be a sponsor.
Well, it's funny you say that. Speaking of state championships, I was talking to Dr. Jaziri, who you had on.
Yeah, he's great.
He's great.
Episode 5.
And he noticed we got into sports talk, right? And so we were talking about VO2 max, and we're talking. Speaking of creatine, there's a great book I think for everybody who's middle age and beyond by Dr. Peter Attia called Outlive.
He's a
I'm listening
surgeon.
to it
He's
now,
MD.
actually. Yeah.
You know Attia?
Yeah.
Yeah.
It's fantastic, right? So he talks of the benefits. So back in the day, I was using creatine. That there's an up and down side, especially for cyclists, right? So we know better now, and you used to have to load a lot, right? So you had those 5 days of load.
They say the loading's not as important.
It's
now.
not as important. Well, and so long successes in the numbers, data, right? So now we know we don't have to load, but especially for cycling, it's power to weight ratio, right? And so how much watts per kilogram can you put out? What's your FTP? You know, I've heard you describe. I think cycling and jiu-jitsu are very similar in terms you're under a lot of stress, and then it's a chess match. The thing I would add to cycling, it's actually pure mechanical racing. It's the purest form of motorsport, except you're the engine behind the chassis, right? So you're trying to tune that engine. So to answer your question about creatine back in the day, I would put on 5 pounds of muscle, right? And then I kind of come out here to California, and I got dropped like a bad girlfriend or, a rock on these stupid.
Way too heavy.
Yeah, I'm way too heavy,
We were just talking about that today. We were watching the Paris Marathon, and Cass was asking me, like, do you want to run a marathon? Do you think we should do that? And I think it would be cool to run a marathon. I haven't run a marathon. I ran a half. And we were looking at the body styles of all the runners.
Yeah.
And she was looking, she's like, they look pretty skinny. And I was like, well, they tend to be because it's an endurance race. It's not a power race, and so like your body at the highest level, when you look at that, it's your body adapts to what the performance it needs to win, and so if you're out running amateur marathons, you may not look like them. You don't have to be worried you're going to get so thin that you're going to break down, but your body adapts to that, and that's the adaptation. It's like your bones get harder and stronger from the impact, and your heart muscle, your cardiac muscle improves its endurance, and it's very cardiovascularly healthy, and the same thing happens adaptation for the bicycle. If you were to go and be a sprinter on the bike versus doing 20, 30, 40, 50 mile races, right, then you get into that endurance realm where you're now it's cost benefit ratio of all that power and all that muscle, where muscle is good, but you can have too much muscle for competition.
Sure, right, because you got to push oxygen and blood through that muscle.
Same thing. You see these UFC fighters, and in the third round at the end, sometimes the fourth or fifth round, these big muscular guys,
they're gassed.
They're just as weak as anybody else.
Yeah, they're gassed.
And that's what I learned about jiu-jitsu is when your body fails because you reach that wall that people call it, right? You are just as weak as if you didn't have these big muscles because they're out of energy. And if your car's out of gas, it doesn't matter if it's a Ferrari. Yeah. It's not going anywhere.
Well, it's interesting talking with Dr. Jaziri, or Jazz, we'll call him for short.
He likes that. He likes
jazz. He likes jazz, as he should. I have a very high VO2 max. And so starting to talk to him about nutrition as XR was launching, I started using it from the day it was available that I could put it in the shaker. They come with a cool little pack of shaker and 14 packets.
He makes it like easy for you.
Well,
he made it easy for me to take supplements.
Yeah, well, we're creatures of a habit, and we like routine, right?
Yeah,
I mean,
the shake way is that's the way
it's
to go.
It's got to be simple.
Pills are such a pain.
It's like people won't visit your website if they have to do too many clicks.
Nope.
Right.
Yeah.
People aren't going to measure so many things every day. It's too many steps. It takes too much brain power.
I watch you guys do it in your practice, right? You're continuing to care of your patients, and everything is systematic, right? I think it's human nature. We break things down. right? And we
I
like
think it's
routine.
always better to simplify things for people.
Oh, KISS,
You know?
keep it simple,
Keep it
stupid.
simple. That's
Yeah.
what Dad always told me.
Yep.
No doubt
sure.
about it.
Did you ever race? Did you ever do any kind of athletic competition?
I did.
or
I actually did
bicycle
a.
stuff?
I did a
what were you
couple
into?
marathons.
You did marathons?
Yeah, I
Did
did
you
a couple.
did you look at your time, or was it like, can I get through this thing?
You know, I actually got talked into my first one with Mark Veras. Actually, he wanted to do one before he was
In
40.
Louisiana?
When we were together in Louisiana, and we ran it was the DC Marathon it's called the Marine Corps Marathon in Washington DC.
You don't have to be a Marine to run it.
No, not at
But
all.
if girls want to pick up on something.
Oh yeah, it was great.
Yeah. We're gonna find some Marine gals out there.
But it was tough. I mean, that's an that whole 20-mile wall is such a real thing.
Did you have any problems running? Did you train?
We trained really hard. We did the whole thing. You basically run a marathon 2 weeks before, so you really.
So you ran a marathon
Yeah.
before, so you knew you could run it.
Yeah, you could do it. And my big mistake that I made was for that one, I bought shoes and I didn't properly break them in. And I didn't figure it out till halfway through the marathon. And my toenails.
Sounds like a learning experience.
Oh my God. My big toenails were black
Oh,
by
man.
the end of the marathon.
Yeah.
To the point where Mark actually had to drill my toenails when we got back to the hotel.
Subungual hematoma.
It was horrible.
Yeah.
Horrible.
Wow. So it bled under your toe.
Yeah.
I ran a half marathon and I was running like 7 miles. I was like, oh, I'm pretty good.
Yeah.
Let me run 10. I ran like 10 miles. I'm like, I'll be fine.
Yeah.
And then I was like, day of, first one, sprinting ahead of the group like a
Yeah.
silly boy, and
Yeah.
and then I got to mile 9. I was like, whoa, this is tough. I got
Yeah.
to mile 10. I'm like,
Yeah.
huh. I got to mile 11. I'm like, I still have 2 more miles. Like
Yeah.
my feet are swelling.
brutal.
My toes were numb.
Yeah.
My hands were numb. I'm like, I don't understand what's
Yeah,
happening.
you get the scrapes from your nipples. if
Totally,
you didn't,
total chafed, chafe, because you have to make sure you got your little cut off or whatever.
Oh,
Well,
my
the
God.
demon
Bad fashion
inside
choice.
is the voice in your head, right? When all that is like going on, you're like,
Yeah.
your feet are killing you.
Yeah.
You're like, why are my hands numb? Like, why can't I feel anything below my rib cage?
Right.
You start that
But-
inner voice creeps in.
But to
thing
your
is,
point, though, with the looking at how people run, I learned that very quickly when I started training. If you look at my video of me running, I don't look anything like the guys that win the marathons. They're gazelles. I mean, they have long legs, they're lean, the muscle mass is different. I'm shortish, squat, kind of. I mean, it's just not going to happen.
We'll say compact.
Yeah,
compact
I'm like,
muscle.
compact.
Yeah.
But it's just not a running.
But you can still be
Physique.
strong. And
Oh,
you
yeah.
can still have good endurance.
Yeah.
You're not going to be the world leader at running, but like Usain Bolt, like these are genetic outliers, right?
Exactly.
So
Sure. Yeah.
what I learned from jiu-jitsu is when you have a match against somebody, you've never met them before, and you kind of size them up.
Yeah.
You look at the big guys and the small guys, and then at first you're like, oh, this guy's big, he must be strong. Oh, this guy's small, he must not be strong.
Yeah.
That goes away quickly,
Yep.
and small guys can know how to use their body like a stiff
Oh
board,
yeah.
and they can just lean on you
It's all
and
about
just
mechanics.
leverage you, and you're just like totally
Yeah.
helpless. So
Yeah.
some of the most ruthless black belts that I know are like guys about your size.
Yeah.
and,
And
they're
you're
just
like-
they will just
They'll take you.
they will take you because they know how to use their body.
Right.
One thing that I learned is like it's really about like fascial, like thick, and you should probably see this too. Little ladies, guys who are doing surgery on, they don't, not super healthy. Let's say it's cuff arthropathy. They don't have like real durable tissues. Their collagen is kind of
Yeah.
like weak and their skin is
Soft.
thin.
Yeah.
And then these other guys, power lifters, the guys who are like, oh my God, this is going to be a hard total shoulder.
Yeah.
And their fascia is just like thick and you can
Yeah.
cut it with
Can't
a
retract it.
scissor.
Yeah.
Right. And you have to like cut it
It's a
to
struggle.
be able to retract it. Otherwise
Yeah.
it's just like a struggle.
Right.
So you kind of have to deal with that fascia.
Yeah.
It's an adaptation. It increases your body's ability to basically be stiff, to give you that pushback, that hydro something pushback,
Hydraulic.
Yeah.
hydraulic pushback
Yeah.
because of the increase in volume. And then the stiffer that compartment is, it's the law of Pascal, I think, right? It's like that gap.
Pascal's law.
Yeah, so like it's that space, but if you increase the pressure in that space, you increase the force.
Yeah.
And so you can have a lot more power. So I think what these guys figure out how to do with jiu-jitsu is like use their body like a stiff board and use leverage.
Yeah.
It's because it's both, because they are strong.
Oh, yeah.
And I think strength and size and weight does matter. When you get into into combat sports.
Yeah.
So did you do any other competitive sports?
No,
growing up?
nothing.
Anything in college or?
No, I've always been, active. I do a lot of yoga now.
Yoga?
I love yoga. Yeah, I do
Yoga's
yoga
awesome.
3 days a week if I can.
So what got you into medicine? Why did you decide to be a surgeon?
My
Medicine's a first choice. Like, I'm going to be a doctor. Or
Well,
did you
actually,
want to be a surgeon?
no, it's interesting. I always wanted to be an orthopedic surgeon, and the reason is I disconnected something.
Oh, here. This is your headphones.
Oh, it's my headphones.
Yeah. Good?
There.
Yeah.
Yeah, now I can hear it. So one of my dad's best friends growing up in Miami was an orthopedic surgeon. And so I started talking to him at some point when I was in like junior high school or high school. And he's like, well, why don't you come watch surgeries? Back then you could just go in and basically, this is 40 years ago
didn't need
now,
a
50 years
badge.
ago. No,
To
you
say,
could just
okay.
walk in.
Surgeon says it's okay. Come
he
by.
scrubbed me in a couple times. I stood there holding my hands. I didn't do anything, but I was scrubbed in. And so from the time I was in high school, I watched orthopedic surgery. This guy was the community orthopod. He was doing hip fractures and total knees and whatever stuff they did back then. And so from day one, I was like, I'm going to be an orthopedic surgeon. So for me, the decision was easy. Go to med school. I knew I wanted to do ortho from day one. And so it wasn't like a struggle like, is it going to be GYN? Am I going to do this or am I going to do that?
You knew what you wanted.
I've always been involved in sports and love watching sports, love playing sports. So sports medicine was what I wanted to do. I wanted to be a team doctor. That was because I knew I wasn't going to be playing, but I could certainly help the guys play better.
So that's very cool because you like sports.
Yeah.
What was your pathway like in medical school?
Med school was, Miami. Miami was a nice medical school. The beauty of Miami, I was there.
Were you from? Are you from Florida? Are you from Miami or?
Well, I grew up. I'm Cuban originally.
You were born in Cuba.
Yeah, I came over when I was 5. So we were dirt poor immigrants. Grew up in Miami, and so I went to. Luckily, Miami was a huge trauma center. At the time.
That was the heyday of the
Colombian drug wars.
Yeah. That's right.
I mean, every night,
trauma.
pretty much when you were on trauma
Penetrative
call,
trauma,
oh my
gunshot,
God,
stabbing.
every night there was like multiple gunshot wounds and, huge orthopedic trauma
Keeps
stuff.
you busy.
So it was great, as a third, much less forget fourth year, third year medical students, you were thrown in, go do an IND, go do a closure.
Yeah, Miami's still known to be a great trauma center.
Yeah,
residents.
unbelievable. It was such a great experience.
there.
So it definitely solidified my love of ortho, And so then when I got into my residency, I definitely wanted to do sports medicine, from day one. So that's how I ended up in Minnesota.
Did your parents have any influence on that, or were they happy that you?
My
decided to
my
go into
dad.
medicine?
It's interesting. My dad, being a Cuban immigrant, my dad had actually started medical school with the guy that I became friends with, his best friend that I sort of followed. So he and that guy had started medical school in Cuba before Castro came on in 1958 or so. And when Castro came in, they closed all the schools down for like 2 years. And my dad never got back because he got married, had 2 kids by the time schools reopened. So my dad never really went back to medicine, And so I kind of...
He was a doctor in Cuba, you said?
No, he wanted to.
He wanted to.
He started medical school, but he never finished it.
Because the regime changed.
Right.
Right. So he found another pathway.
Yeah.
Okay.
Instability there.
Wow.
Yeah. And so he ended up I think he probably ended up talking me into it a little bit, or at least talking it up, and then when I met this guy, it was so cool to be a high school student and watch surgery and stuff.
Well, I would imagine he had to be
unique.
intensely supportive as like his ambition
right.
in his native land.
Yeah.
And now his son's over here.
Well, you probably have a better pathway here.
Yeah.
You can probably a lot of
sure.
other countries have family in Mexico, and they go through the pathway to be a doctor, but to be a doctor in America, it's there's higher standards to get there, and you kind of once you get through, as there's a lot more opportunity.
Well, and there's no doubt. My brain is kind of flashing sort of my background is that there's no doubt your family certainly grew up on government cheese, right? And then finding that pathway.
We'd go pick up the cheese.
Yeah, remember those?
Month.
Right,
yeah,
right.
Cheese
and
block.
with the green and white label. Same thing.
Hey, man, everybody
US FDA.
Right. Yeah. I mean, both poor
USDA.
kids from the ghetto. I mean,
100%.
that's crazy.
Yeah, it gives you what they call grit. They call that grit these days.
Angela
Well, I've
Duckworth,
shown, my kids they're 23 and 26 now, but I remember a few years ago we always go down to Miami for Christmas, and I showed them the first apartment we lived in. It was myself, my older
Adios.
brother, and my younger sister, and mom and dad, and we literally lived in a studio apartment with like half a bedroom. It wasn't really. And so I showed the kids the neighborhood, and they're like, "What? What?"
Yeah, we call it perspective.
They grew up in
kids.
Calabasas in the Hidden Hills, you
Perspective
know.
on dad.
Right. Yeah. How many
That's gonna
people
make it
died in
nice
this
for you.
alley?
Yeah.
Right?
It was
That's crazy.
scary.
So,
Right.
did you do research there in medical school?
At,
Did you
at
develop?
Miami, I did a lot of Miami at the time did not have a huge basic science, so I actually published a couple of papers on, it was all trauma related follow up.
When did you get interested in doing a resident, or so you were a resident at, where did you do residency?
I did my residency in Philly.
In Philly.
Yeah.
So at Einstein.
Yeah.
So how was that? How was your Einstein experience?
Einstein experience
Because they have a lot of trauma too.
Yeah,
right?
they had a fair amount of trauma, but it was a little bit more controlled, so it was nice. We did a lot of sports medicine, and that's kind of what got me started. It was just in the beginning.
Sports.
I mean, this was 1988 is when I started my residency.
Did they have arthroscopy?
Just barely. Like we would.
Lanny
this is kind of
Johnson?
crazy. Well, he had just come out. It was interesting because a lot of times I remember doing this distinctly. We would scope patients like for a shoulder scope, and we didn't have lateral. It was all beach chair at the time. So we'd do a quick diagnostic arthroscopy because we really didn't have MRI either back then. So we would do a diagnostic scope, look around, say, okay, this guy's got a cuff tear or whatever, bring the patient back 2 weeks later.
It was a true
wouldn't open.
diagnostic scope.
Yeah.
It was just like, let's see what's going on.
Right.
Confirm the diagnosis.
Right.
You
And
need
then-
surgery, sir.
Right. And then have the guy come back to the office and go through it. Okay, we need to do this open thing, blah, blah, blah. And so that's how we did it for years.
So it was scope, show you have a tear, stop,
right.
and then come back for an open procedure to fix
Yes.
it.
Yes.
Wow.
Isn't
That's
that
very
crazy?
different than how we do it today.
Yeah.
Now we, as you know, diagnose it on MRI,
Yeah.
have a plan, and
Yeah.
then scope and fix the tear
Yeah.
most of the time.
And there's some
you can still-
technology that you can scope in the office now.
Oh yeah.
Definitely.
Yeah.
Definitely.
It's
the
pretty-
nanoscopes.
Yeah.
Yeah. But that was pretty crazy. It didn't make any sense. I don't know. I guess there was some idea that somehow the arthroscopic fluid would make it more difficult. And I guess the consent was the issue too. Like you didn't really know what you were getting into with the patient. So you had to go back and say, okay, well, you've got a big tear, you've got a little tear, whatever it might be.
Right.
So it was sort of an interesting dynamic that you don't have to do that anymore, thankfully.
Seems ripe for trying to figure out a better solution. 'Cause
Yeah.
That I'm always curious about how these changes happen, because you have so much inertia, with treatment. And, hey, what does Carlos do? What does Mike do? It's like, what did we learn in training? It's kind of similar to what the other guys on the West Coast do and the East Coast do. And
Right.
it all is kind of medicine. And it's like, how do we know all these secrets? Oh, they're all in those books.
Yeah.
And you kind of read the books, and the guys like you write the books, and me and I help write the books. And then we kind of say like, oh, we think this is the best way to do it. And then we look at the evidence and we kind of say, there's complications here, So like, are there complications because of how we're treating it, or is there complications because of who we're treating, or are we selecting the right procedure for them?
Yeah.
So it seems like that was a good way to get more understanding of the pathology, because it seems like at the time you didn't have a clear understanding of the pathology and the natural history even of rotator cuff tears. Why is this thing torn?
Yeah.
You didn't injure
No
it.
idea.
At the time it was, why does this person have a tear? You
It
didn't
was
injure it.
impingement. It was your acromion.
It must be impingement because it must be hitting. There's no other explanation for
Right.
this degenerative
It was
process.
dumbed
we're
down,
seeing.
at the time.
Yeah. And so natural history with Ken Yamaguchi, I think, really helped our understanding, and Jay Keener eventually, because he was a fellow there. And then, it really improved a lot of our understanding of the rotator cuff. We're still understanding like the rotator cuff. It's a major aspect of the last meeting, the shoulder 360 meeting in Miami.
Yeah.
Did you come to that?
I did not.
You didn't come.
I
It
couldn't
was
get
it was
to
a great meeting with Joe Abood and Rafi Mirzayan and Paul Sethi. They put it on every year. I think this is the fourth
year. Yes,
And
sir.
it was just excellent this year because it's everything else. It's like, why are these things healing most of the time but not all the time? Is there a genetic factor? We know, but it's kind of this concept review of what's actually causing this problem. And what the understanding is more and more is there's people with a predisposition to bad shoulders. There's predisposition to bad hips, as you know. And I wanted to get into some of that too.
Yeah.
What are some of the differences that you've seen with the shoulder? Because you're a specialist at the shoulder and you're a specialist at the hip. You do hip arthroscopy. You develop these minimally invasive methods where you can do debridement of removing the bone, so you're preventing impingement because it's more of a constrained joint, right? And there's less muscle forces in terms of
Right.
stability, but it relies on the labrum and it relies on the
bony stability,
The bony
yeah.
stability.
Yeah.
Whereas in the shoulder, you have much more motion, but that socket joint is just so much smaller, shallower, and it's reliant on the labrum.
Yeah, it's a
and the
soft
capsule.
tissue case.
And
Right.
It's just all soft tissue mostly, right?
Yeah.
And so as a hip specialist, shoulder specialist, you do both. You also do minimally invasive arthroscopy, and then you do shoulder reconstruction. I find that fascinating.
Yeah, kind of all
I
over
don't know
the
anybody
place.
else that does that. It's fascinating.
It's interesting.
I'm
'cause
sure
I
there's
think-
people, but
Yeah,
you've developed techniques in that you've seen the development of arthroscopy.
Yeah.
Like my training has all been with arthroscopy, and going back to some of the old techniques are still useful. But arthroscopy is a great thing.
Yeah.
But it could still be better.
Yeah. Oh, for sure.
And,
Yeah.
and I'm always kind of thinking of ways to make these things just like better,
Yeah.
and maybe there's a way that we can select them. What have you learned about the hip and the shoulder? Is there would you like one better? Do you like the shoulder better? Do you like the hip better? Or is it kind of like they're both interesting because we haven't fully solved them?
That's I think that's been the driving force behind my sort of developing all these different
You just
areas
can't decide.
of expertise.
You like them both so much, you
Well,
can't decide.
it's so fascinating because like take hip arthroscopy for example. My first hip arthroscopy is a great story, and I was in New Orleans my second year in practice. I had never ever seen a hip scope, done a hip scope. And I was on trauma call with the residents, and I get a call from the chief resident. He says, "Hey, Dr. Guanche, we have a prostitute that got shot in the hip.
Oh boy.
3 a.m, and we're going to do a hip scope." And I'm like, "What are you talking about? Hip scope? What? Let's just do an IND."
It might be a bullet in the joint, right?
Yeah, it was. You could see it on the X-ray.
Yeah.
And so I'm like, I don't know what you're talking about. He goes, I got this article by this Tom Bird guy. It was 92, I think it was, a brand new article. And I get to the OR at 3 a.m. and he's got the article plastered on the wall,
Is that plumbism, or does it have anything to do with like lead toxification?
Yeah,
right?
we just wanted to take it out.
Yeah, because it actually can cause third body wear in the joint, actual damage.
Well, this one was right.
And it gets absorbed by the body more so because it's more vascular.
Yeah, no, this thing was right in the middle of her joint.
Oh my.
And so I was like, okay, let's try it. We didn't have any equipment, so we just used the knee scope stuff. And she had gotten shot right in the front, right where we would create an anterior portal. So I basically put the scope in there, and I ran into some of her blue jeans that had gotten dragged into, because when you get a gunshot
the entry wound,
a lot of the stuff gets dragged in from the
Be
skin.
careful with that. You don't say entry and exit wound. You know that, right? Because the lawyers, when it gets up in court, you don't know for sure because you weren't there.
That's right.
True.
And so I basically just blindly went and grabbed the piece of blue jeans out, and I put the scope back in. We were looking at the bullet. And so we're like, okay, this is our first hip scope. And so now the bullet is stuck in the acetabulum. So I used under fluoro, I used a Steinman pin, knocked the bullet into the joint, and then just kind of went in there under fluoro, grabbed the bullet, and then we washed it out. And that was my first hip scope. And then
That kind of sounds like the first hip scope.
it was for me, and for the
in Louisiana it was.
Never in Louisiana.
Louisiana.
That was the first.
That's cool.
And so the residents would take care of a lot of the prisoners, and a lot of the prisoners were very, very active. These guys, Louisiana's a hard labor state, so the prisoners were either working out
Breaking
or
rocks.
working, doing hard labor.
Yeah.
So they had a lot of injuries, and so the residents were looking for hip scopes.
Wow.
So that's how I cut my teeth on hip scopes.
That day on, you're the hip scope guy.
From that day on. And so that's and what I find fascinating, and even today, we really don't know a lot. We know a lot more about shoulder than we know about hip.
Really?
Yeah, I think so. I think as far as
I
how
thought
to manage.
the opposite was true.
No, because there's so many variants. Like the anatomical. If you start looking at a plain film of a hip, there are so many nuances there. That's one of my favorite talks to give. If I do a grand rounds for residents or fellows, I always just put up a bunch of X-rays and say,
Talk about it.
Tell me what you see.
Mm-hmm. Probably talk about it for a half hour with an X-ray.
Half hour for each one, even each hip on a patient, because there's so many nuances of the bony anatomy that really impact stability, and so there's so many complexities there that we're not quite sure what's the right procedure to do on certain patients. What do you do with the capsule? How do you fix the labrum? Do you do a labral reconstruction? There's so many debates in that area that it's still up in the air 25 years later.
What do you think the biggest problem in hip surgery is?
I think it's
or for patients, like what's the biggest problem in terms of like what causes problems for people?
It's anatomical variance for sure. I think that there's two big groups. I think impingers are one big group where they have like extra bone, basically is the
extra bone in the acetabulum.
Both acetabulum or the femoral head. The femoral head has an extra bump, or the acetabulum has more bone, and so they are what's called overcovered, essentially. So that basically when they start to flex their hip, the two bones bump into each other, and that's why you get the soft tissue breakdown. So that's one. But then the other area,
so too much bone.
The other area, which is a lot more subtle and a lot harder to manage, is the patients that have less bone than they should, and that's dysplasia is sort of the broad category. But there's a bunch of variants.
So not enough coverage.
Not enough coverage. Yeah. So your hip is relatively unstable. But it's a volumetric. It's a 3D problem. It's not just like if you just look at an X-ray, you're just seeing part of the problem, more the lateral part of it, but you're not really seeing the volume of the acetabulum at the front, the back, and also the soft tissue laxity. So there's so many variables, just like the shoulder.
Dynamic
really.
variables.
It's the same idea,
yeah.
Right?
How do you think about it in terms of when you see a hip patient? Is this something that you think of in terms of like dynamic problems that might be affecting them? Say you have the diagnosis. Those are the easy ones. That's impingement. We see that. I know what to do. We got to shave it out. Too much bone. Easy problem. Easy fix.
Right.
What about the ones that are unclear? Like is there undiagnosed instability that you can't really assess? Like, is there a collection of patients that you just haven't really fully understood, or do you kind of see that your treatments kind of get them better regardless? Do you think that there's still unsolved patients?
There's a variety. I would say probably my guess is 20-30% of the patients are still, they end up having to give up a lot of their.
That's surprising.
Yeah,
20 or 30%.
I think so. Yeah,
Do you think there's 20 or 30% of people that don't really get better, or do you saying that?
Or don't get good enough to the point where they want to go back to what they want to do,
despite
like
treatment,
high impact, like high impact sports or higher level sports.
Is that with adequate treatment?
With treatment, yeah, I think, and same thing. I mean, if you don't have the acetabular volume, the only way to really correct it in many cases is to do an osteotomy where you reorient it. But even in those cases, there's still a sort of a lack of volume of the hip. So it's not like you're solving, you almost had to add bone on both sides of the joint. You can't just rotate part of it.
If it's still small, you only have so much to work with, right? You can kind of put it in the key area that would be better.
Yeah, so those people are really, and then there's, besides the pelvis, the femoral anatomy too, the femoral version, the femoral rotation. So there's so many
spinal
factors.
Pelvic tilt.
Spinal pelvic, older patients, we run into that a lot.
And flexibility from the spine too, because that could
issue.
affect how much dynamics they have in their hip.
Right, huge issue.
It starts to get much more complex.
Yeah.
We kind of akin that to the importance of the shoulder blade, the scapula, in terms of how we don't quite understand how that thing moves and functions very well.
Right.
And I think the more you try to understand it, the better your kind of overall treatment can get in terms of making people better.
Yeah.
Because sometimes like the muscle dynamics of the shoulder can be off, and that can really affect. It kind of gives you a view of what's going on inside the shoulder. So sometimes I always look at the back, and see how their shoulder blades, if it's kind of up, or
down.
If they have normal motion or if they have stiff motion, those things tend to go together, and you see these patterns.
For sure. Yeah. No, I think I'm not working with fellows now, but when I always worked with either fellows or residents, and I always insisted you better take their shirt off, or if it's a woman, have them put the gown underneath their armpits and stand in the back first. I always look at the patient from the back and see are their scapula even? Do they sit funny? Are they up and then look at them from the front. Same thing. Some patients will sit, they'll sit like this, where their whole scapula is like sitting down, and a lot of like posterior instability. How often have you seen people miss posterior instability because patients are kind of holding it? You think like there's something anterior. The problem is they're protecting, because every time they go back, their shoulder subluxes posteriorly.
Absolutely.
So that's a huge thing that a lot of residents and fellows don't even They don't know that.
It's because it's a subtle finding a lot
It
of
is,
times,
yeah.
and you have to really be akin to these small, changes, maybe like a Bennett's lesion in a
Yeah.
picture where you can see a little,
Right.
hypoplasia, and you put that together with their symptoms. So that's why I think being a good diagnostician has so
It's
much
huge.
value.
Huge.
Because doing it's talking to the patient, maybe looking at a basic X-ray, and then doing a good physical exam. I can gather 90% of what I need to know and
Yeah.
help that person,
Right.
at least set them off on the right path.
No, it's amazing how I often see this, and I'm sure you do too. You'll see patients in the office where you'll examine them and they say, "You're the first guy that's actually touched me." Because most
Really?
I
guys,
make it a point to always touch
they'll
my
talk to
patients
the
examine
patient,
them.
they'll look at their X-ray,
want anybody
and they'll
else
look
to
at the MRI read. They won't
Right.
even bother looking at the actual MRI imaging.
Because
Which,
it helps you make the decision. Hey, we need surgery. Why do I
Right,
need to
that's
care? If I touch you or not, we're doing surgery. We're gonna fix it. But it's critical because it still changes how I do the surgery.
oh, big time.
you know?
Yeah.
And it can affect timing, can affect what the patient's looking for too.
Yeah.
Do you see more stiffness in the hip in the patients that you treat? Do you see more instability? Do you think there's a difference in terms of age factors for those things?
Yeah, the instability is typically the much younger patients for the most part, and females. Just like in the shoulder, it's really the same issue. A lot of the men that have
So stiffness
impingement-
more in the old and instability in the
Yeah.
young, similar to the shoulder.
Yeah, and the older stiff hips are really, what I mean by old in this case is really more like the 35, 40-year-old men predominantly.
Sure. That's
They
when it
start
starts
to
happening.
get stiff.
Yeah.
They start losing their motion, and then those are the guys that come in that confuse you a lot, because they'll come in and they'll say it hurts in the back, it hurts in my knee, because they're sort of basically protecting their hip. And so their knee is working overtime, their back is working overtime. So those are the guys that get really confusing sometimes.
How do you assess people's backs?
I try to, yeah. And a lot of them, you have to get x-rays, as much as I hate to,
How much do you get X-rays on stuff that you don't treat? Like, say, do you get hand X-rays? Do you get back X-rays? Do you get neck X-rays? Do you just kind of say, "Hey, go see your hand doctor"?
I try to, yeah.
You do?
Yeah.
If it helps you make a diagnosis,
Yeah.
maybe.
I see probably the more common one is actually neck,
Yeah.
and I'm sure you do too.
Constantly.
'cause
And a lot of the times
post
people have
op,
neck
I still
problems.
have that pain down
Yeah.
here, and they're like, okay, let's get an x-ray of your neck
Sure.
and see what's going on there.
Give you some
know?
answers.
Yeah.
I usually tell them too, the neck stuff takes a long time to get better. I've seen neck problems get better from shoulder surgery.
Oh, for sure.
Definitely. Especially stiff shoulders when it's
Yeah.
like it's constantly overworking.
Yeah, they're
or,
doing that riding.
Yeah.
Yeah.
or bad rotator cuff tears even because they're stressing that muscle.
Big
It's like,
time.
why does it hurt right here? It's like,
Right.
well, this is torn, so that's doing all the work.
Yeah.
It's kind of simple like that.
Yeah.
What do you see your future in terms of the hip, in terms of the shoulder? Do you like both? Do you want to continue to expand either one in terms of techniques, or how do you see the future going for those types of procedures?
Probably, I think the big thing in the shoulder, I think we've got a pretty good feel for arthroscopic procedures for the most part. I would love to see a better solution for the younger patient that has that massive irreparable cuff that, right now in my hands, I think a reverse is probably the way to go.
Even in a young patient?
And relatively young.
How young? If you can't fix it, say it too big.
I have done 45-year-olds because I just think it's a better way to go. I mean, I'm old enough to have done a fair amount of the latissimus transfers, and to try to get those people for it to function is bad. I mean, I don't think I was doing anything wrong. I think I'm as good as anybody in terms of actually doing a procedure, but the return of motion was really 50-50. It was a bit of a crapshoot. So I wasn't thrilled with it. When the reverse started coming, at first everybody was scared, like, oh, a huge complicated. You probably remember
Notching,
the first articles.
dislocation.
It was
Well,
like,
the first words, from my perspective, we had Gilles Walsh and Pascal tell us, nobody in this country is going to use this because this is a salvage procedure only.
right. 30% complication
30% complication rate.
Plus, Near couldn't get it to work.
Near
And
couldn't get it to
was the
work.
guy who invented shoulder
Right, and so
replacements.
they
That
had almost 10 years of data before they came to the U.S., right? And I'll never forget it. I joke, like another outlier example is Pascal and Gilles are training us in 04 at the back of the ESH meeting down in La Jolla and saying,
hey, take a look at this backward shoulder.
well, not just that. The exact words were, this is a salvage procedure and there's no
Don't use it routinely.
Well, and your surgeon doesn't have an option to get out of this.
Right.
When this fails,
Right.
that's
Yeah.
it.
Well,
So-
I think there's some paternalism there.
Yeah.
well, so that's 20,
Yeah.
now 1 years ago.
Right.
But
right?
what I've seen though now, 20 plus years after the fact, is the reverses, and I've done them, I did them at SCOE for 21 years. Few and far between come back with a problem. Occasionally you'll see the notching, but it hasn't been a clinical problem, as you know, for the most part.
Data supports it, yeah. Not
And
the problem they thought.
I don't see reverses coming back with failure, but I see a lot of totals coming back with failure.
I agree. And Joe Abu just published a recent study looking at the durability and the return to function after reverse compared to anatomics.
Yeah.
And I think you can put them both in great. And there's more things that can go wrong with the anatomic. And if your cuff fails, your reverse should still work pretty well. So that kind of makes sense to me. And maybe putting reverses in better and making them more durable might be the answer. You know, a better reverse might be that. The hip replacement got me thinking. A hip replacements are done really well these days. Pennenberg, one of our partners, was talking to me about how durable hips are these days, and they're just ceramic hips with polyethylene
cups.
Probably 30
cups.
plus years.
That's what he was saying. And he's like, the trends don't even look like they're wearing significantly. So they might last even longer than that. And then with Wolff's Law at play with bone and metal interfacing, loading the bone should make that interface stronger, because now we're biointegrated. We're integrated with the technology of the metal and the bone, and it should get stronger as long as it doesn't get infected. But even sometimes you have these well-ingrown components, and then something happens, they get a little infection. But you can sometimes even treat through that if it's something small.
Sure.
So the durability of these implants, I think, comes into play, especially when we're treating people in their 40s, 50s, 60s, 60s even, because they might live into their 90s. A 60-year-old today that looks like you, a strong guy that does, bicycling. It's like my patients, I'm sure you see too, they look great into their 70s, sometimes even to their 80s.
Easily, yeah.
And I think that was even different from where I trained, maybe East Coast, or maybe even 10 years ago is different. There's just a different
dramatic difference.
Difference in health these days.
So. Yeah.
And fortunately,
and expectations on their part too.
Well, because it kind of pushes us to more to better outcomes, and really selecting patients that we can help with the right type of procedure. So I think being a specialist at those things, we can offer people a lot, because they call them demanding. We have demanding patients. I don't like, it sounds negative, but they have a need from going from 80% to 95%, and if they can get to that 90, they're never going to be 100, but if that 80 to 95% or their 30% to 80% feels awesome.
Right.
But to go from 85 to 95% is, you got to make things perfect.
Yeah.
You can't mess anything.
No, you got to try it.
And sometimes things still get messed up. So what I've been interested in lately, and I think I want to get into a little more discussion with the reverse, but there's been more talk about development in terms of arthroplasty components with the shoulder. Maybe you're kind of played out. How much more of the sigmoid curve can we get on? Because the early curve, George Athwell was talking about this. The early curve is, hey, we can't really figure out reverse replacements because they're not working, and then Grammont comes out, and then the curve goes like this. Yeah. Everybody's like, yeah, this is going to work. How do we make it better?
Right.
And that's when, the masters get involved, like Walsh, and you were involved in some of that early development with the reverse, with the Delta, right?
Delta,
the Delta DePuy implant. And I want to hear a little bit more about that, your early involvement. But, this curve is innovative. And so you were on that kind of early innovative curve. And I think that's where, people can have a big difference in making things like, hey, that's working, but this is better. Let's use that one. And then you slow that curve down. And I think we're on that slow end of that curve, because all the implants are about this big, right? This long, not this long anymore.
And
you can't tell them apart. Kind of an inset cup, and they're kind of 135 instead of 155 angles, right? So everything is kind of coming towards the middle, right? That's kind of the average. So now that we're at this kind of easing off of that curve, looking at other ways to make our patients better definitely become more impactful. And so with the AI stuff, with technology, the way it's going, the way that the ways that we're putting the implants in and selecting people, I think is much more critical.
Yeah, some of the CT guided stuff I think is important, especially for the guys that don't have a lot of experience. I don't use a lot of CT. I don't know about you, but
I do. I use it a lot early, especially where I would get a CT scan because I learned from it,
and that's what I did.
I was learning as a surgeon, so it was helping me.
Right. So now I look at a plain film and I have a pretty good feel for, obviously with revisions and things like that, I get a CT scan, but I don't get them near as much. But I think for the younger guys, especially starting, I think it's really critical to start to understand it better.
Early on, it's helpful just to get CTs if you're doing shoulder arthroplasty. I think it's helpful.
Yeah.
Now I get CTs if there's any deformity,
Right.
you know, because I know I'm not as good as understanding the deformity. You know, you can argue if you have perfect x-rays, you can probably be pretty close. But for me, if I see any deformity, I just get a CT scan because I know with the 3D, it'll be easier for me to understand the deformity and with more predictability. Yeah. And then as Pat knows, what I do for my case is I'll do the surgery online, and then I put the implants where I think they should go, and I'll kind of vary things. I'll say, oh, you know, it's a little too much tilt for this, maybe I'll use an augment, so it helps me make decisions. You know, or if I'm between an anatomic or reverse for bone quality, not because of the cuff, you know. And so if I'm looking at like, I just don't want to augment this much,
the
or
glenoid.
if I might, you know, the inset, the glenoid, or if I'm doing an anatomic, that's a good way to size the glenoid, figure out if I'm going to inset it or onlay it. So I definitely use it to make decisions for deformity.
Yeah. No, and I think the approach I've talked about, getting to the glenoid is still tough for a fair amount of patients. So I think there's probably different ways to get to the glenoid, maybe from the side. Like I've thought about, you know, trying to do like a minimally invasive approach that's actually like almost like a transdeltoid, like just a small incision to do some of the drilling and preparation.
Yeah. Yeah. One thing I think could really help with the development is, you know, we're trying to use this robot through our standard techniques. It's not going to work.
No.
I mean, the robot works to help with cuts and making things more precise, but because the total shoulder is such a soft tissue operation because of the anatomy, you know, compared to a hip kind of makes more sense. You can really machine it, you know, because the robot, a lot of the helpful aspects of that are the machinery behind it, like a CNC. But with a soft tissue operation, one thing that I had an idea about was, you know, we see these Da Vinci robots, how they have these portals, and then you have this like more fine soft tissue management. Right. That makes more sense to me for shoulder
that's where I think
robotics.
we need to go.
I think so too.
Yeah.
You know, because we can have a camera and maybe access points from the front and the back, do our releases, you know, and then the thing that we have to think about differently, though, is the implants.
Right.
You know,
well, what it sounds
how do you
like
deliver
how do you deliver the implant?
Well, what it sounds like you're both saying is minimally invasive like a Da Vinci and also soft tissue sparing. So what ultimately is going through the interval for a subscap sparing. Yeah, going through the interval.
Rotator interval.
A rotator
and
interval.
Posterior interval.
Yeah.
Right? There's ways to get access. We do it with scopes. You know, that's minimally invasive.
Reaming you could ream the glenoid through. You can almost make like a small poke hole through the deltoid, through the humerus even.
Maybe three holes, right? Yeah. Something like one access, one viewing, and one working.
Because then your patient leaves with their subscap intact.
Oh, I think there's a lot of benefits to that, even with the reverse. Why take down the subscap?
After you can,
absolutely.
So it will be the next frontier, I think, is minimally invasive arthroplasty.
Yeah.
You know, and the techniques right now are open techniques that we're trying to get to work with these jigs, and you know, we've talked about some of these things, and it's a constantly evolving process, which is really cool. But it is one way to get there, right? We can watch TV on YouTube, or we can watch TV on our TV, but we're watching stuff that's entertainment, you know? Yeah. And so sometimes you can't get the right stuff on YouTube. You're never going to get it on your TV. So sometimes if you're going through certain channels, it may never pan out to anything. So what was that like getting involved in DePuy and getting involved in like this corporate company that now has this vision of how things should work, and they put you on these projects and say, all right, Carlos, you're going to work on how long the stem should be, but just that, how long the stem should be. Like what was that like?
You know, I think part of the problem,
because that's an opportunity to say, yes, I will absolutely, you know, be on your design team.
The problem I think with those things is that there are so many, as you know, like you put a bunch of shoulder surgeons in a room, everybody's got their opinion about what the right thing is, and you know, it really, the loudest guy gets his opinion heard the best, and that's what it ends up being, you know. So it ends up being not necessarily a consensus, but just the person that's got the loudest voice in the room in many cases. That's what I saw with Arthrex, especially. That's where I worked more with early on with their total and the very beginnings of their reverse.
You're saying it's a room full of egotistical cats?
Pretty much.
Which cat is going to take over today?
You know?
Right.
Yeah. Well, we're all like that, you know. And
yeah.
You can only be quiet until you just got to say something. I disagree with you, sir. And then it's just kind of behavior, and
but it's good. I mean, it's obviously pushed the envelope, you know.
But that's what you need. And I've been in these meetings as well, and you know, it's like that. It's like that. It's gonna be like that because it's a bunch of guys who think differently. Right. But what's cool about certain teams is you may be able to come up with some new stuff, like Ignite, like what those guys did.
Ignite guys,
it's like the top guys, different understandings, but hey, let's come together to work on stuff. stuff.
Yeah.
I think the next frontier for that is independent thought, where these guys are forming groups that are powerful. Because you can't really be on your own anymore. It's just that type of world where your ideas can be there. I have a lot of good ideas, maybe, and it's like they're only ideas until they come and produce something.
Well, you need
that is a
somebody to
product.
refine it for you.
Absolutely.
Because
You can't. What I've realized is you can't do things on your own. I can't do this podcast by myself. I got to have my friends on to talk to you.
Right,
It makes
right.
it better. It's just better when we work together.
But as you get there, you have to prove of concept first, and then have your peers and colleagues validate that, and then it's the infancy. You got to, going back to what you're talking about with like pin guides and then AR, VR, all these overlays of technology. You have to crawl, walk, run, right? And so right now with managing glenoids is coming back to what you're talking about, is we're kind of in the infancy of this.
Well, that's why it's such a cool time, because now we've developed these products. That's kind of what I was getting to. Like, we've developed these cool products. Well, why keep trying to make them better per se? You can make little changes. Like Mattson's study showed, total shoulders are total shoulders since NEAR came out, basically.
Right.
Yep.
It's
Hasn't
like a ball
changed.
in a socket, and if it loosens, then it'll be problems. But
like
well,
this.
if you can
Yeah,
develop,
there you go.
This is the original
Is that the NEAR?
That's a
Mark-
OG
Mark
NEAR.
Mark II?
What's that?
Mark II?
Well, read it right on the thing. It's a Kirshner.
Put this one on the camera.
Yeah.
There you go.
Pretty cool.
So there's a great quote, and I'm one of these nerds that go to all the shoulder meetings.
So 135 next shaft?
Yes, sir.
Oh, it still is, isn't
it's
it?
It's a
You had
monoblock.
two or three sizes. I can't remember.
Yeah, they had 2 or 3 sizes.
Look at the backside there.
It's crazy.
Yeah,
huh?
it's crazy.
He's like, I think this will work.
Oh,
right.
yeah. It's got a good shot.
Yeah, it's so basically, let's take the hip,
Very cool.
right? Cut off the neck on the hip, put a ball on a stick, right? But as I was saying, there's a great quote, and I can't remember the surgeon who said it. He says, "As great as we think we are, us hairless talking monkeys, we're replacing shoulder arthroplasty with metal and plastic." And where's the bearing surface innovation, right? And we know bone doesn't like plastic.
But I bet NEAR didn't have trays like you guys have.
Well-
Their trays are pretty developed. It's a lot easier to get in these days.
And if you're talking down
And
the
that's what I talked to Frankel about this, because I said the same thing to him,
Mm-hmm.
and Frankel was like, "Yeah, but if your system sucks getting it in, you're gonna be a shitty implant, And he was totally right. Like if your
100%.
cut jigs are off, and
Right.
the implant could look awesome, but like,
Yeah.
guys, how do I give me the tools? Your tools are breaking,
Yeah.
It's like you got to have good tools and reliable
100%,
instruments,
and a good
and a
carpenter's
good surgeon
right,
to
and
put it in.
a good carpenter's not going to blame his tools either, right?
But he'll get feedback and say, "Hey, your tool's broke. I need a better screwdriver."
100%. But
To try to improve it.
Yeah, try to improve it.
But to the point of your question is where's the innovation in implants, right? And so why do shoulders have the problems? Being in Dr. Guanche's room, 100 shoulders a year for 20 years, you see everything,
User error.
right?
I think most problems come from user error.
Well, Pete
Or the host. It's like the patient's not optimized. They don't have their nutrition right. They're doing something. They're smoking.
Well, there's a
or
whole.
they had this
Yeah, sure.
infection, and we have this ability to put things in and make it perfect, and then we got to rely on things will be okay. But the implants are implants. They just sit there like this. This is inert, right? But this could also lead to an awesome outcome with
Sure.
the right combination.
With the right carpenter putting it in.
I could,
Putting it in.
him and I could make this work. And
Absolutely,
most people,
yeah.
right?
I used to
Right.
joke like if I gave Dr. Guanche a
With
stick
a cob. I need a cob though.
Yeah, that's right. If I gave him
Cob
a
and a
stick and a
knife.
meatball, he'd make the shoulder work. right?
Totally.
Right? So it's restoring, it's understanding your soft tissue envelope tendon, your muscle belly tension.
Yeah.
Right? So
What's the approach even?
yeah.
Oh,
Well,
definitely.
even
I mean,
the
how much-
approach.
Soft tissue approach.
How important is
how
that?
you access each soft tissue structure along the way.
So you mentioned AI, right? So AI. So we've been
I love
taking.
talking about AI.
We've been talking about taking CT scans, rendering them into a 3D image, and now being able to read the playbook. Your Christian Gerber has a great quote. If I do the surgery on my head before I go in the OR, I have a better chance. Right? So
It's they call that
Visualization.
visualization.
I've
right.
done that. It's so funny because I didn't know about visualization about probably 10 or 15 years ago. I read a book. I can't remember where I read it, but they were talking about
What's that?
I read it from Gladwell.
maybe it was Gladwell.
Might have been.
And I thought to myself, I've been doing that my whole career.
Yeah.
Like while you're scrubbing, getting ready for a case, a lot of times I would be thinking about, okay, step 1, step 2, step 3, You know, it's so funny. And sure enough, you go in there and you're doing it.
Anticipation and
Yeah.
knowing what you're going to see and say, hey, if I see this, I'm going to
Yeah.
do that. But if you don't, then I'm
Yeah.
going to keep going.
Yeah.
Right. That's how you really
Yeah.
get to,
And that's what I've done for years. Like when I come
especially
into,
for revisions.
Oh,
You know,
yeah.
any
gosh.
kind of
Any
complicated
complex
cases.
stuff.
Yeah.
For years, I've always, like, even if I had 7 cases on my schedule, I would always go into the office early and go through my patients for that day, look at their imaging, write down some notes. So I'd have, you know, a little cheat sheet. So I'd pull it out between.
I had
every
a
case.
surgeon at USC that did that, Seth Gamrat. He used to write them on
Yeah.
paper, his
Yeah.
steps to the case,
Like 3 or 4
every time.
Yeah, like 3 or
And
4
he would
key
paste
points.
it, and we'd all
Yep.
look at it. I was like, that's fascinating.
Yeah, but I always did
Because
that.
I thought it was like, this guy's, of
Yeah.
course he knows his surgeries, but why is he writing out his steps to make
I've
them
been doing
perfect
that
every time?
32
That's why.
years. I still do it
That's
to this
amazing.
day. You know, and it
Remarkable.
helps because it really, you know, you're prepared. There's like no, because every once in a while there's some weird stuff in your X-ray that, oh yeah, I saw it when I saw him in the office, but that was 2 months ago. You know, and if you don't look at it that day, you'll miss it.
Yeah, I tend to put it in my plan of my last note.
Yeah.
And then I tell my PA, make sure you read my plan of my
Right,
last note. And then remind me that day.
Yeah,
But you got to have a way to remember.
Yeah,
like,
it just
system,
takes
right?
10 minutes, and it's
Yeah.
you know, especially now with digital. You know, it used to be a pain in the ass with you had to pull out your X-rays, and now it's so much easier. There's no excuse. Like it frustrates me with the fellows. The last few years, we had, you know, fellows that I've worked with my whole career, and they have gotten so lazy with that aspect. You know, like
Jerry Williams
How-
used to paste, as a fellow Jerry and at Rothman,
Yeah.
we used to paste 20 pictures up on the wall, literally
Yeah.
tape for every single case.
And if you
20,
didn't do it,
and
you
had
didn't
to
do the
be-
case.
Exactly. It had to be in the right order with all of the background. It would be the cuts of the CT, the X-ray in the right order, just so he could be doing the case in case he happened to look up and be like,
yeah,
okay, looks good.
yeah.
And then you'd keep going. But if you didn't have that, it was just like you weren't touching anything. That was just step one.
No, I
you
know.
know, and so it's like learn what that guy does, and that's kind of what I did. That's what Pat does.
Yeah.
You know, Pat learns us really well. You know, and he becomes friends with us. He's you and I have been great friends, and you've been so helpful.
Well,
you
thank
know, in
you.
the OR, before the OR, planning cases. Hey doc, what do you think about
Yeah.
you know this?
They'll
idea?
look
Why
at it
don't you
3
try
days
this?
before. Like,
Before,
what do we
it's
need?
so helpful to have somebody that's looking over things.
Yeah.
You know, even it's because I do a lot of complex cases. You know, with the shoulder, as you know. And there's a lot going on. You know,
Yeah.
there's a lot of planning, and sometimes things still get screwed up. You know,
Yeah.
and so he knows that, and having
Yeah.
the experienced rep like that really can make a huge difference on a busy
Oh,
OR day,
Dramatic difference.
and help the patient out. Help the
Yes.
patient out. get
Well,
that
and you're
gamma
talking
going
about
out.
technology again, right? So what I think as a rep side of it is now we're in this space where we're using technology, pin guides, preoperative planning, CT. We're able to read the play, halfback sweep right before we go in, and we know if there's anything else going on. And then we're ready for any complications through that. And I think what all of this technology is ultimately trying to help you guys do is do it accurately and in the best target, right? Because you can do it accurate, but sometimes you can miss the target, right? A spitball gets by everybody once in a while, right? You got a change up, and all of a sudden you're like, oh, I didn't see that version coming, or how did this collect it? And so what helps you hit your target with the best precision in the best bone stock, right? And that to me, that's the target. So when you say, hey, why am I looking at this 3 days ahead of time? It's because I want to think like you to help you solve problems if I can see it from the sideline,
Yeah.
right?
No,
And
it's
so
very helpful.
it's but ultimately, to your earlier question, is we're still using plastic and metal. Like, what's the next bearing surface? And it may not be pyrocarbon.
What do you think the next big evolution of arthroplasty is going to be? Like, what's the next thing that's going to be big? You could argue things haven't made a big difference so far. You can say robotics, technology, AI, like these things are having an impact right now that I think we're going to see where they go. What do you think is going to be the next big thing? It might be one of those things. Like, what do you think it is? If you could pinpoint one thing that would change arthroplasty,
If I think
that's it for both of you.
Yeah. I'll give the dumb answer first to help him. He's going to sound
me
so
some
much
time to
smarter
think.
after this.
That's why I asked you first,
Right.
so you could think and look
All right,
good.
ask the dumb white guy.
I gave you a little bit.
Right. If I'm in Disneyland, I'm playing make-believe here, I ultimately think you have to get rid of polyethylene. You have to come down to a better bearing surface.
Bearing surface.
You're thinking about modular elasticity to bone, right? And you mentioned the Ignite guys earlier, and I think those are some really smart guys who have tried to think like a surgeon to give you, what do surgeons want? Minimally invasive, but if I'm playing make-believe, it has to be some sort of bearing surface. right? Where we get plastic out of it, right? So, and I don't know what that is. Is that ceramic? Is there a technology that's out there that we haven't figured out? We've seen polyethylene glass spheres, right? We've seen every iteration of a bearing surface.
Yeah.
And the tricky thing with shoulders is, as you said, it's a soft tissue case. And what I like about, and this is where my brain goes with all of this preoperative planning, 2D to 3D, and now is it the metaverse, right? And augmented reality with holograms.
We might be in the metaverse now. You don't know that.
I like to think so.
I didn't know you were serving
That's how I
pizza
live my
toppings
life.
with the,
My life in the
right,
metaverse.
pizza toppings and tequila, sweet.
But so bearing surface because of the wear debris. Would you say? I mean, like, why is that the problem? Do you think?
Well, I think bearing surface because
Because they wear out.
well, it doesn't last. Everything I've seen in
So
20,
increasing longevity.
longevity.
That's what you want.
Bone doesn't
You
like.
think that would help?
I think
Well,
getting
it would
rid
help
of
total shoulders for sure.
It would definitely help
That's where I
shoulders.
see all the time. That's
Yeah.
the failure point.
Well, our bearing
It's never
surfaces
the
are different
It's
than
never
the hip.
the humerus, you know.
yeah, it's not the humerus up until.
Well, are
in
you
all
talking about
defense,
anatomics?
Yeah.
I'm
So
talking
how do you-
anatomics.
so you have arguably more experience, maybe combined, than us
Sure.
with seeing total shoulders fail.
Yes.
And revisions.
I probably have.
What is
yes,
the
sir.
number one reason for revisions? Like for failure of total shoulders.
Failure
like,
of total
that
shoulder-
you've seen from a revision perspective.
From a
like,
revision perspective, osteolysis. Yeah.
it's the glenoid.
It's a glenoid.
Yeah.
Yeah.
It's the data's there. It's non-cross-linked plastic, right? No matter what variation it
Yeah.
is, we've discovered, thanks to Dr. Frankel, vitamin E polyethylene.
Plastic particles.
It's plastic
They
particles.
cause a lot of problems
They
in the
cause
body.
a lot of problems, and also implant design. I would argue short stems, and my opinion, not copy approved, whatever you want to call it. Short stems were a solution to a problem that didn't exist, right?
I think so too.
And so
I've actually gone back to standard stems.
Yeah,
Right.
I do too.
Yeah.
They're straighter and they're more predictable. They
sure.
don't cause. I just leave them small. They don't cause a
Yeah.
problem. Look at this
right,
Yeah.
standard length stem. That's pretty much what I
Right.
use.
right.
Not for anatomics, for reverses for
But
sure.
sure,
as
yeah.
opposed to that technology, that's just basically bar stock steel that's polished. Where depending on what device you're using, quoting Ignite, this is a porous structure that simulates the bone. Right, so what do you want? You want good fixation,
Ingrowth.
and ingrowth.
Yeah,
right.
Wolff's Law.
But plastics, exactly. Wolff's Law.
Plastic
Lowe's.
doesn't follow Wolff's Law.
No, it doesn't. It does not. And so my brain goes osteolysis. We did a nasty Universe 2 earlier in the week. That's just a patient.
Yeah. Half the glenoid was gone.
Half the glenoid was gone.
Yeah,
I mean,
I've seen catastrophe from these on-leg glenoids, and if they loosen and then they
Sure.
rock, and then they can
Sure.
cause massive bone loss.
Sure.
Uncontained defects, which
Yeah.
is
That's how
significantly
she.
different.
Yeah, this lady was
yeah.
horrible.
So
I think one benefit to circular small glenoids is really just less plastic
Mm-hmm.
in there. You know, with high strength polyethylene,
Yes,
that
sir.
should have less wear and keep it contained. So if it does fail, it fails in a contained method.
yeah, I think that'll help.
Not massive
Right.
catastrophe.
No, I agree with you.
Well, and I think you guys could probably agree with me on this. It's also about a conforming glenoid, right? So
I don't know about that, Pat. I don't know about that. I think the opposite could be true with conforming glenoids because of the translation. I think that might edge load and actually cause edge loading wear. What do you think
Interesting.
about that, Carlos?
Even though-
do you
you
think
mean
it
on
stays
the-
centered?
What's your question?
So Pat was talking
I was talking
the
about a
fact that
conforming joint.
Oh, yeah,
conformed because Jill Walsh did early studies on this, looking at the mismatch of radius of curvature.
Yeah, yeah.
You know, because for the hip it's fully constrained.
Right.
For a reverse it's fully constrained.
Right.
You know, these kind of make sense to me for durability.
So maybe-
this may not be good
It may
for
be-
translational forces.
It may be the reason for the failure.
I think it's a
Yeah.
part of the reason for failure.
Dr. Murthy and his colleagues have a paper about cuff strain on anatomics because
Right.
you're
If they're tilted up.
superior inclination.
Right.
Now you have your head banging against your
I
cuff.
think he's right.
And that's how you end up
It's
with
what
cuff
overstuffing.
arthropathy. That's
And-
the
yeah.
main failure for these
Overstuffing
guys.
causes that. A big head. Even
Overstuffing.
if the glenoid's perfect, if you ever put a big head, it's
Yeah.
going to
100%.
stress that cuff and
For
fail.
sure.
So my answer to that is a conforming glenoid that will keep that head centered in that sock, because a healthy shoulder doesn't migrate up and down, north and south on the glenoid. It stays.
Are you sure?
Well, I don't have an MD at the end of my name, but
We don't know. I don't know.
But looking at the literature, it shows where's the deepest part of the vault. Every joint is going to articulate on the deepest part of the vault.
By definition.
by
So it
definition,
shouldn't
yes.
slide north, you're saying.
Right.
Yeah.
I because the bicep is a depressor, and your cuff is in a healthy shoulder. I'm saying, not a degenerative, arthritic or RA shoulder, but in a healthy shoulder, it makes it. The reason I say conforming glenoid is because that 1-to-1 match and keeping it centered. Now, I could be crazy, and you guys can kick me the hell out of here.
I wonder if part of me wonders, like every once in a while, I mean, I'm sure you do a tenodesis all the time on total shoulders,
routinely.
but you almost wonder, like on a total shoulder, should you do something to maintain that? Because the biceps clearly does some depression, and maybe that's part of the reason that our totals fail earlier.
Do you think Neer had it wrong by trying to fix an anatomic problem with an anatomic solution? Do you think total shoulders are maybe not the best way to do a total shoulder?
Yeah, probably. Yeah.
Could be. I mean,
Some people would say that.
I have heard it, and I can't disagree with it.
Yeah.
Right? The evidence shows that direction.
I think it's starting to go that way a bit.
Yeah.
Because I think the reverses may be more durable.
Yeah.
You know, and I think I look at an anatomic as the right patient who doesn't really have a lot of deformity and their cuff is solid. They don't have atrophy in their cuff.
Right.
They don't have degenerative changes. They could be young, they could be old, but they have to be active, you know, and that's a pretty select person.
Yeah.
And then when I do it, I say, this is going to be a Ferrari that might only last 15 years, maybe 20 years if you're lucky. Because the literature tells us they fail at a rate of 70% by 15 years.
I've seen
75%.
My average, and from what I've seen in the 20 years here, 12 to 14 years.
Right.
And I'll see them
and
come
I've
in.
seen them fail before that.
Yep.
And then they got a problem to deal with.
Right.
So another arthroplasty surgery, which is a revision, is a real thing.
Yeah.
If I look at my reverses that I have to revise, it's usually because of a problem. You know, how many of my own reverses
They were put
have
in
I
wrong.
revised?
Right.
Well, I didn't put them in wrong. You know,
Somebody,
but my own I think I've had more failures percentage-wise for my anatomics than my reverses.
For sure.
Right?
Oh, 100%.
You know, and I don't know if it's me putting them in wrong, but I'm pretty good at putting them in.
No, I don't think so. I think it's just the mechanics of the device.
I think so too.
Yeah.
There's just more things that can fail.
Well, I mean, you think about it, you don't know on any given patient, you don't know that they're going to develop a cuff tear anyway.
We're relying on soft tissue healing.
Right.
That's
So
the problem.
It's the cuff tear.
Yeah.
That's what starts, I think, that's probably why they start to slide, sublux more,
I think you're
cause
right.
more wear.
I think you're right. It's
So
an
it's probably
instability.
a cuff issue.
Yes.
Yeah.
I
And I
think.
think that's probably why knees don't function like hips.
Right.
It's like shoulders don't function like reverses. We should put it that way because, it's a constrained joint. The hips function well because it's just this durable.
That's it.
I think a reverse might be the better solution for
That's why I
shoulder. I
Well,
think.
the data's going that direction.
I mean, some
look at
guys in the
20
community would say like you're fucking crazy for doing that, but I really,
But
in
we're
my
at,
hands,
we're at the apex of what's going on.
yeah. I mean, I've seen it for 30 years, and that it seems that those are the patients that are holding up very, very well.
Andy Jawa just got convicted of putting in too many reverses at the meeting in
Really?
Miami. Yeah,
Yeah.
they put him on trial.
I saw his
Did you see
highlights.
that?
Yes,
Really?
I
I'm gonna
did.
show
Yeah,
a little
it's
clip of
great.
that.
Oh,
It's
that's
great.
funny.
Well, because
It was one of the funniest things I've ever seen in my life. Here, I'm gonna put a little screamer. for
Wow,
you.
that's crazy.
yeah. And
See,
he's-
I would probably be.
Yeah,
I'm sure I
I
would
was
be
going to say you
convicted.
might be in solitary in the cell next to Dr. Jawa.
But like I said, it's based on failure of all the
well,
other
right,
part, you know.
and I've had the honor of kind of sitting with him because he's one of the design surgeons on the Ignite, and like you've done for me is just filled my head with here's what I'm seeing, here's why. I mean, this is why it's Plan A, right? Which
Right.
just helps my skill level to.
Here's Joe Boone. Look at
Oh
this.
my god.
So they were putting him on trial, saying that. Yeah, look at.
I was gonna say, can you throw that to the camera?
Yeah, yeah.
Oh.
No, it'll be on. It'll be on there.
You'll do it on there.
Yeah, yeah. So watch. Check this out. This is Jawa. They were putting him on trial at the
my
Miami
God.
He
meeting.
was in orange scrubs.
Yeah, yeah. Watch. So this is him pleading for his. This is him pleading for his freedom.
Increase number of reverses that you're actually doing. Do the increase number of reverses that you're actually doing. Otherwise, show me the long-term data.
So this guy,
Otherwise, show me the long-term data that you're right.
Yeah, look at that. That was the whole jury.
Oh
That
my
was the whole jury
God.
right there.
That's
Sperling was right behind him.
Do the increase number of reverses that you're actually doing. Do the increase number of reverses that you're actually doing. Otherwise, show me the long-term data that you're right. Otherwise, either way, I don't give a damn. According to public opinion, as defined by
Amen, brother.
practicing surgery, we're actually putting in 70 to 80% reverses. Clearly 80% reverses.
Yeah, that's about.
I think that's accurate.
That's my practice.
I
I'd rather that you just
So he's the guy, with Jacob Kirsch, one of the prior fellows from Rothman, who I know well, who is really one of these big research guys, and Jawa's a big research guy.
Yeah.
He's doing all these cases, and he's looking at these things saying, maybe if we just do a reverse with a good cuff, you're going to do better than if you have this terrible cuff and you're still getting a reverse.
Yeah.
Because the FDA on-label indications basically say you need to have cuff dysfunction for a reverse.
Right.
You know,
Yeah.
but who doesn't have some aspect of cuff dysfunction? You know,
but I think that's
and what may
critical.
happen
I
to
can
your
raise
cuff
my
in
hand,
5
right.
years. So you can't tell me for sure. I know your cuff is going to be good if I do an anatomic in 5 years. So he has a good point saying
Yeah.
that
Sure.
you know, if I'm concerned about the durability of your cuff, you're going to have a predictable outcome with the reverse.
You're much better off.
I think
Yeah.
so.
Yeah.
If you can put in a good reverse.
Oh,
Yeah.
yeah.
There's problems with reverses still. I still get stress fractures
Yeah.
in little old ladies with poor bone.
The skinny little ladies.
Absolutely. And so I think there's more and more coming out about the
Yeah.
importance of DEXA scans, about assessing their bone quality, and about it really assessing their nutrition.
Yeah.
One guy I had on my podcast, Jazz, as you know, episode 5, he was talking about how easily you can calculate the GNRI,
Yeah,
the
that's crazy.
Geriatric Nutritional Risk Index, which is based off of the albumin.
Low
if your
protein.
albumin is 3.5 or below,
Yeah.
they're nutritionally depleted. Don't
Yeah.
do surgery on them.
Yeah.
That's
They're probably
crazy.
going to get a stress fracture. It just, you know, and he gave grand rounds recently at Cedars.
No, I think a lot of older people, I've learned that, you know.
But just check
Just-
to see. Let's just check and let's just wait.
protein
okay?
intake is huge,
Yeah.
huge, dramatically decreased in older people. They just don't.
You should be taking 21 grams of collagen a day, just regularly.
Yeah.
That's what plastic surgeons recommend.
Yeah.
And
protein,
dermatologists.
like 10 grams per kilo. You know, like really, like you really
Yeah,
need
check.
to go after,
one gram per kilo.
Or
One gram per kilo.
yeah,
right.
about 1.2 to 1.5, I
Yep.
think.
because otherwise you're deficient. And most patients, I think most patients will probably eat half of that.
We're not
You
eating nearly as much protein as we think
Yeah.
For
we are.
sure.
So I go out of my way to, but
Yeah.
that's what I do.
You have to go out of your way.
Yeah.
I've been telling my patients to eat more steak.
Yeah.
You know, I tell them my post-ops, I say,
Go have a
what was your
ribeye.
diet? Like, oh, that's pretty good. I'm like, when's the last time you've been to a steakhouse? And they're like, we're going tonight. You
Yeah.
know, because you should go eat a
Right.
steak.
Yeah.
And cardiovascular disease and these things, it's like in the short term, you need to get enough protein to heal.
It's-
Let's worry about that.
Yeah.
You know, make sure
maintain
you get
your
enough
muscle.
good
and how
collagen,
important-
creatine, all those
If you don't
things.
have muscle tone to keep your balance, that's the huge morbidity from that. you know?
Absolutely. Hip fractures, proximal humerus fractures, distal,
yeah.
distal radius fractures,
All these
most
things,
common
yeah.
insufficiency fractures.
Yeah. Terrible.
And why am I going to do surgery on you and increase that risk of all these risks,
Right.
these fractures?
Yeah.
You know, you might
Yeah.
fracture your hip anyways because your nutrition has been
You're
well.
malnourished.
Let's get you focusing on the things that are going to get you to heal first.
Right. Yeah.
Then I'll talk to you about your shoulder surgery.
Sure.
So Jazz does a pause. You know, he does a pause like, I'm worried about this person. Let's check their labs. I like, you know, like you should at least kind
So
of
he
look into
tunes
these
them up
things.
before he
tunes
does-
them up. And if
Interesting.
everything looks good, let's go.
Well,
Yeah.
it's funny as we were talking as this XR was coming out
No
about
rush.
my
I got a major backlog. Let's let's
Right,
slow this
right.
down.
Right,
and
right. Let's feed
look
you
at- yeah.
and get you
Right,
up to
feed you.
speed. And it was funny. I shared with Jazz my ACL replacement that you did many years ago, and the importance you even told me of keep riding your bike till the day I do your ACL. Keep your muscle tone. Keep up your nutrition.
Yeah.
Taking a lot
the
of
stronger
protein.
you are, you're going in, the stronger you are coming
The
out.
stronger you are, recover. And then a couple years ago with the XR, it actually helped me win a championship, picking Jazz's brain, my own nutrition, and I realized, to your point, I kind of switched to plant-based. And he looked me straight in the eyes. He's like, "You got to add
Yeah.
more protein to your
Real
diet,
protein,
and there's
yeah.
no way your life
Straight up.
Well, you guys have very stressful lives, right? So to really think about your personal nutrition day to day, you're depleted. You know,
Dude, since he's been on the podcast, I haven't been eating my regular nutrition until recently. I've been like, yeah, everybody should be on the right nutrition. Yeah, I'm like, hang on, what am I doing?
You're not
It's like,
doing
what
it.
did I take
Yeah.
today?
Practice
I didn't-
what you preach, brother.
Exactly.
Yeah.
But you have to go out of your way and make an effort for
Yeah.
that.
it's hard.
No, I do. For a
That's
few
why you need
years
a
now.
girlfriend that does yoga, right?
Like, I did.
She'll help you.
I did go out for a while with a woman who was actually worked with Olympic athletes and their nutrition, and so I learned a lot from her, and that's why I've become a big proponent of the whole
For
you know,
sure.
protein.
Yeah.
Make
It's-
sure and
Once that bell rings, you can't
huge.
unhear it. You can't
Yeah.
unsee
yeah,
it.
it's like
and
Inception.
I'm at I'm 63, so I'm like I can see like if,
critical.
if I don't stay up on it, I'm
You're
gonna
63?
I know, Dan looks
You look
damn good,
damn good.
right? I look
Damn
63, right? Maybe 83,
Those
really.
Cuban genes.
Yeah, right.
Yeah, it must be. But I think it's important because I can see it. Like if I slack off, if I don't work out for a week,
It's crazy.
I see it happen, and I hate it. You
Yeah.
know? And so I just And the same thing with the diet. If you don't eat good food, you're not going to build it. You're not going to build your protein, your muscles back up if you're not eating the right stuff.
So what do you think it's going to take to make those changes? I mean, I personally think it all comes from surgeons, because patients will listen to us implicitly. And, that's why our patient trust for us is so important. We can't ever, mess that up, right? Because our patients come to us looking for answers and looking for truthful information. And sometimes we just don't know, but we give them our best thought on the current state of the art. But it's our job to kind of know how to lead our patients to the right thing. Whether or not they do that, that's up to them.
Right.
But I like being a good source of information. That's part of the reason I started this podcast, so I can get more people on and spread more good information from people that I think, understand things in a way that can really help people. You're a hip specialist. I don't know a lot about the hip, but the way that you can kind of put things together with your understanding and your knowledge of those things can help a lot of people.
Yeah.
You can really help people on this one-to-one basis and give them good information.
Yeah.
What do you think will make a difference for people with this kind of knowledge and understanding? I recently asked that question for some higher ups, that I think would be responsible for helping, from a public health standpoint. I don't think it's our job to really educate from a public health standpoint, but what can we do either for our patients or what can we do for other surgeons to kind of, encourage this adoption of some of these new things that we think will be helpful for outcomes and care?
Yeah. I think, I think nutrition education is horrible. I mean, we didn't learn it in medical school.
Not at all.
Everything we're talking about, you read it on your own. I read it
absolutely
on my own,
on my own after medical school and residency.
Yeah, for sure. So I think education is huge, and so I try to make an effort, like especially for my older post-ops, to really talk to them about nutrition and make sure and eat the right stuff. Not only
you talk to them that way.
I try to, especially protein, because I see that a lot on these. How many frail little skinny people do you see that are in their 70s? They're chipper and everything, but you can kind of see like they need a little bit more substance to their body. And you see
an effect on it too. I've seen people really increase their diet. They start getting on nutrition, and the next time they come in, they look much better.
So I tell them, I drink, there's OWYN as a brand of protein shakes. I don't know if you're familiar.
I haven't heard of that.
Only What You Need.
Is that the company?
Yeah, Only What You Need. It's an acronym for that. And
do you have any relationship with them?
No. I wish.
No, I mean, that sounds like something that.
But I have one every day.
Put a surgeon stamp on that.
Yeah, because it's got 30 grams of protein in a shake, and it's got a lot of greens.
We're not getting nearly enough. If you actually calculate the protein you need, calculate it.
Oh, it's 50%.
You're not getting enough. You are. But most people. And then you have surgery. You probably need more than that.
Right.
That's why Reza showed us that GNRI calculator, but
that
it also
calculator
shows a muscle calculator too, so you can look at your macros you need for surgery.
Yeah. It's amazing. Yeah.
You shouldn't really base it off of calories.
No,
that's old thinking.
Well, you mentioned in that podcast, like the pyramid probably wasn't the best accurate.
No, it's way off.
It's way off. But again, it's there for a reason, for whatever purpose it served. But again, as I've heard Jazz and now you both say, this isn't anything that we learned in school, right? No. All the nutrition I learned is I grew up coming out of high school and in college. All my buddies were bodybuilders and wrestlers. I was the skinny dude out of all of them that had the endurance genes.
Athletes at least have kind of a start on understanding
exactly
nutrition and carbs.
And bodybuilders
and
have. I haven't met a high level performing bodybuilder who is. They're generally savants because they know what's coming in, what's going out,
totally.
And you need that recovery. You need that muscle growth. So
they know the timing.
They know the timing exactly. Yeah. So, and that's important. You're right. And I see with your patients, like, at being on the fly on the wall, looking at X-rays, being in your clinic. Like, I start thinking about it. My grandma, my mom.
Yeah.
It's like
and supplements too, like anti-inflammatory, like chondroitin, glucosamine, even like cinnamon or curcumin. There's a lot of anti-inflammatory stuff that. Some of these older
turmeric, all that stuff.
Yeah, they're taking.
But now there's science behind it too.
Yeah,
there's science.
And so I tell them, I write them down. I should actually put a little sheet together for them because I write it down. And I'll just tell them, look at these anti-inflammatory things instead of.
You write it down.
I do. I'll write it down. You know how we have those little sheets in the office with our name on them? I'll just write down like 3 or 4 things.
Well, we should print something.
We should.
Yeah, standardize.
That would be smart.
Hey guys, we might take a quick break.
Yeah.
I gotta go
for
really
it.
Bad.
All right.
Yeah, I'll let it run though, okay? And we're back on the LA Shoulder Podcast. I had to take a quick pee break. Sorry, guys.
Hey, now.
So we're back now. So, Pat, I know we were talking about nutrition. That's really cool stuff. I think there's a lot more coming on nutrition. I think that's something that
no doubt about it.
RFK has been talking about changing the food pyramid.
Yeah,
food pyramid has been crap for a long time.
It's unbelievable when you.
It's like,
when
hey
you
guys,
look
eat
at
mostly bread. That's good. Refined bread.
it was horrible.
You know,
Horrible.
eat a little bit of fish. Fish is good.
Yeah.
You know, fruits and veggies.
Don't eat eggs. Don't eat eggs.
Don't eat eggs.
Yeah.
Low fat.
That's
That's
just
bad.
stupid. The whole thing is.
What
just,
they've been finding lately, if you've listened to Huberman podcasts,
Yeah.
I like
Or
these
Attia-
podcasts.
Attia's
Attia has been good.
Attia's
and these
great.
guys go on each other's, and they kind
Sure.
of
yeah.
talk about like what's right and what works. But they're scientists.
Yeah.
A lot of this stuff needs to come from credentialed scientists.
Yes.
Medical doctors. Let's start there. Some credentials.
Mm-hmm.
And I think podcasters have a huge voice, but they may not have the credentials. But they ask good questions, and they have a big audience. And so
Yeah.
getting the right people there, I think,
Yes.
is critical.
Mm-hmm.
To
For
hear
sure.
from the experts.
Yeah.
On the LA Shoulder podcast, where we go shoulder to shoulder with the experts. Do you like that tagline?
I do like
yeah,
that.
Gev gave me
Yes.
that one.
Yes.
Gev gave
Love
me
it.
that
Oh,
one.
did he?
Yeah, I think I'm going to use that
We're
one.
going
That's
shoulder
great.
to
We're
shoulder.
going shoulder to shoulder with the experts.
Yes. Love it.
I love it.
And so with the nutrition stuff, the food pyramid was backwards. Now the government, I think it's their job to tell us what's healthy and unhealthy. Fluoride in the water, is that good? I think we should ask a question about that. Lead in the paint.
more
I think
I
we should
hear
ask
about
questions about the public
Yeah.
health segments.
Fluoride has been a problem, I think, the more you
Yeah.
read about
For
it.
decades.
I used to drink, it sounds crazy. I used to drink the tap water here, with the one with all the crummy stuff in
Yeah.
it, and you're just
Yeah.
like drinking your water. I got a water filter literally like maybe 6 months ago, and I swear to you, I just can think more clearly now.
Yeah.
I was drinking
surprised
because when
me.
I was doing
Yeah.
jujitsu, I would drink this giant gallon of my own water
Yeah.
every single day, like water.
Right.
I think I was maybe getting too much fluoride
Well, when I first
because I
moved
stopped drinking. I was like,
Yeah.
there's an effect. Do you drink purified water or do you
Yeah.
drink tap water?
I have my house. I have like a whole filter.
Yeah, so you
thing.
probably never experienced that. Your brain
Yeah.
works normally. But
Yeah.
fluoride had I think it has
I
a
don't know about
suppress-
that,
Well, I mean, there's a little,
all
there's a
relative.
couple wires crossed. But the cross wires just make it more
Yeah,
interesting.
right.
But like there's definitely something with that, and with plumbism and lead effects and
Oh, for
these
sure.
like public health concerns for things that are toxic to our
Well,
bodies.
look at Michigan, the problems they had.
Flint, Michigan.
They
Lead in
could-
the water, right?
Well, I don't think it was Flint, Michigan, but they were literally the gas that was coming out of the water you could light on fire. It's
Oh,
crazy.
yeah.
So
Impurities and
the impurities and
Toxins.
whatever the company was that.
What we know about toxins is that they are cellular toxic. They
Yes.
kill the cells.
Mm-hmm.
So if something kills a cell, what are we made of?
Yeah.
Basically cells and
That's
like
horrible.
water within
Yeah.
that cell.
Yeah.
And so if we see these things causing problems, then we know that our government ideally or some kind of protecting agency like the Food and Drug Administration or these are like these governmental organizations that are able to pass things through for quality. That's why the US is so unique. We know that if we just go buy it, it's not going to kill us, right? If the doctor prescribes it, it's probably going to be safe and okay. And generally that's true. We try not to cause harm. That's in our oath. But like with product development and with making new stuff like biologics, the FDA said, no, you can't mess with stem cells because you might cause cancer. And we didn't cause cancer, but
Yeah.
it happened, and they tried to mess with genetics, and then this kid got cancer, the bubble boy.
Yeah.
And that pushed us back for stem cell research a lot of years. But stem cells are very, very cool. My mom's husband is trying to convince her to get stem cells.
Really?
I was like, Mom, who is this guy that's giving you the stem cell treatment? She's like, I need to talk to you. I'm like, yes, of course. Talk to me first.
Is she going out of the country or in the
Well,
US?
it's in the U.S.
Yeah.
Well, look
And-
at what
and-
they're doing with that woolly mouse, right? The genetic alteration that basically they have a genome from a woolly mammoth and they bred mice.
Yeah.
CRISPR technology.
The CRISPR technology,
Yeah.
right?
Yeah.
And then you talk about I may be misquoting here. I don't want to get you canceled, but I think it was a dire wolf. They actually brought it to
They-
existence.
Yeah.
It was extinct.
Yeah.
Right.
Right. So we're in a very I'm gonna sound like an old man. We're in a very unique space in time and everything where we are in terms of technology and what we can do with biologics, genetics.
Yeah.
As we talk about all this technology and where it's going.
It's like Jurassic Park. It's like making dinosaurs.
Yeah.
That's what Michael Crichton was talking
Oh, yeah.
about.
Yeah.
He's like,
Same
this is
idea.
this
Well,
is this technology
I
that's
actually-
moving faster than humans can
Yeah.
be like, is this a good idea?
100%.
Should we be making
Well,
dinosaurs?
I was talking with my 20-year-old son, and I literally were having dinner the other night, and I said, it's crazy. I was talking to you a couple years ago about coding, and what we know now today is that AI will be doing coding at an exponential rate.
Coding.
Yeah.
Yeah, yeah.
Right?
Yeah, it's outsourced now because you have ChatGPT. I can code.
You don't
I
have to
code.
learn it.
Right.
I just use
You don't need to
ChatGPT.
learn coding anymore, which could be a valuable skill 2 years ago.
You can't see the future past 2 years for
Yeah,
sure, because things are just
100%.
going.
If you're lucky. Yeah.
It's not linear anymore.
Yeah, yeah.
The AI's gone like this.
So
Crazy.
biologics.
But that's cool. It makes it interesting.
Yeah.
But
Yeah.
who knows? Like, it's a very powerful tool.
Yeah.
And I think humans are just kind of like, humans haven't caught on to AI enough yet. You know, it's like you have to be rapidly adopting these things because
Yeah.
you're just going to get outpaced so quickly.
Well, we already have Neuralink.
The what?
Neuralink,
Oh, yeah.
right? I mean, 100 years, 200 years, call me crazy. I mean, we're going to be integrated with computers.
love it.
We're already doing it,
We
right?
know it.
I mean, it's going to be like Johnny Mnemonic,
Yeah, I think that's
or
yeah.
Neo from the
We already
Matrix,
are.
right?
I mean, the
Can't live without
technology
this.
kind of is there.
We just have to look at
already.
it. We have to listen to it.
Yeah.
You know, we're integrated, but
It's gonna be
It's not
integrated.
osteo
Yeah.
integration. It's not bio integration
Right.
yet.
It will be.
It will be
Something you swallow.
because it'll be
or
faster.
just like a little
Well,
pellet.
Well, I think it comes through these neural signals because we have this giant neural node on our brain,
Yeah.
you know, that has all this like energy. It sucks up all this glucose and then produces a
But
little
how do you
bit
give
of
it
heat,
continue with all that technology? How do you give continuum of care?
you can interface,
Right.
You need an interface to be able. So we're going like our progress is going to stop because of biology, you know. So like
Sure.
right now I am looking for human solutions, right? But like our technology, we can use that to help the humans, which are like biological problems. And like when the aliens come back, which we know they're already here, they're going to look at us and gonna be like, these are humans and
Yeah.
they are very slowly adapting creatures and they rely on this tissue healing,
Right.
which is fibrosis.
Right.
You know, so all of our stuff is kind of stimulating fibrosis, you know,
Yeah.
for healing. And that's fine because that's how we heal. And I think it's actually really cool that we heal because the Mark II? It can't heal. It's inert.
Yeah.
You know,
Yeah.
you break it and it stays that
That's
way.
it.
Right.
But we can heal, which
Yeah.
is actually very exceptionally cool. You know, and so as surgeons, like the better surgeon you can be, you can just like restore anatomy and let Jesus take over. You know, let Jesus heal your wounds because I think that's how it works.
No,
and
I
so,
agree with
you know,
you.
harnessing this genetic technology becomes very scary.
Well, if I could just be for clarity, Jesus doesn't heal your wounds. Biologic.
Jesus does heal your wounds. You tell my mom Jesus doesn't heal your wounds.
Oh my God.
right?
Well,
my mom will
there's
argue with you.
It's a product. It's a product.
'Cause I don't
That's a
heal
whole nother fight.
I can't fight
That's
that
another
battle. That's a
podcast.
religious battle.
Well, it's a product of all boys Catholic school and a
Yeah.
Catholic education. My brain goes to the scientific side. Just for clarity and joking, like Jesus ain't healing your cuff, bro. Okay, he ain't
Yeah,
making Sharpie's fibers, right?
No, but he is. I think he is.
Yeah.
What I'm saying when I use the term Jesus,
Yeah.
I just mean like some otherworldly
Sure.
force.
It's a
Whatever
miracle.
this force is.
There's a
that
force
does.
that heals things.
how we heal
We
is-
allow.
How does
we
your
s-
body know? I mean, it's amazing.
Well, the
you know?
liver, the
amazing.
liver's crazy. Right?
Everything in your body is replaced every 5 years or something.
Yeah.
So like, but your
Yeah,
cells
look at
somehow.
your face structure changes. Your bones
But-
turn over. That's
but
like
you remember
no, your bones are
everything.
bones. They don't
Right.
change. No, they're
Yeah.
alive. They're
Yeah.
cells. They
Yeah.
change. Your bones
That's
change.
huge. Yeah.
For
Your
sure.
body changes over time.
Oh, absolutely.
Your
Yeah,
face structure can change.
We're
Yep.
constantly evolving. Yeah. So
You know, you think your body temperature is 98.6 all the time?
No.
Or is it like this? And sometimes up, sometimes
Yeah.
down. You know,
Yeah,
it's like this
it fluctuates in a
average.
variance, right. Mm-hmm.
Fluctuation. Absolutely. We're dynamic beings.
Yeah.
We're never the same. We're always changing.
yeah, we're somebody's petri dish, I think.
And that's why the nutrition concept is so interesting because, you know, we don't know. We don't really know. It can drop and it's dynamic. It's constantly changing. And then surgery changes that too. So like we need and then some people need more, some people need less.
Yeah.
Maybe you have everything you need and you
Right.
heal fine. But it's just an interesting concept I think that needs to be studied more. It's
Yeah.
like figuring out
Well,
when
that's
to
what
intervene.
PRP, like PRP, that's the classic thing. Like,
What do you think about PRP?
I think there's something to it. I think unfortunately the variability from patient to patient, from device to device, is so huge that I don't even know what we're doing with. Does it work in some patients? Absolutely, and then other times it doesn't do a thing.
But
and
even if you're standardizing your dose and all of that.
I think there's something to it. I think it probably stimulates, the areas that I think it works for, that I've seen results are partial cuff tears. I
Yeah.
think it's reasonable.
Yeah.
Patellar, like quad or patellar tendon, hamstring stuff. I see it for a number of hamstrings. So
Do you think that how much it works is dependent on how much it costs? Or do you think those are two separate things?
no, I think it has to do with the patient as much as anything.
PRP
PRP
is your question.
Yeah.
Because I was
And
going to say,
maybe there's an access to care issue there where some people are not getting it because of the cost, and it may be working better for those people if the costs weren't an issue. That's kind of how I feel about it. Like,
Okay.
I think it's somewhat of a barrier
Yeah.
because of cost of care for certain people, and that might limit and maybe skew the results of the outcomes to people who have more money that can pay for it.
Probably, yeah.
the
you're
studies
probably right.
showed kind of were similar, but I think the indications are key for PRP.
I think part of the problem with the studies is also, as Dr. Guanche said, is the devices. And being in biologics for a very long time in my career, side by side with being sports and shoulder arthroplasty, there's a great paper in Harvard that actually tested, probably now 12 years ago, maybe 15, all the PRP systems, and it ultimately comes down to your capture rate. Or my dumb analogy is, if you're trying to capture corn syrup out of high fructose corn syrup out of a can of Coke or a 2-liter, that's going to be a 2-liter. You're going to get more syrup, right? So you're trying to capture the platelets, and then you put them in the right spot: rotator cuff, right? Tennis elbow, patella, etc. So, but unfortunately, because of the way the FDA approval is, I think there's a high variance in what the patient has to pay. And again, the FDA doesn't approve. The FDA,
it's not even FDA approved for those indications. It's FDA off-label. So PRP is approved by the FDA, but it's not approved.
It has a big blanket approval, which is very strange for any, because I've been in biologics so long. The PRP FDA approval is at, I'm going to water this down.
For every joint or every
area? To discretion of the surgeon, basically. I'm going to water it down. So that's why it has.
But that's like saying that, I think a stemless reverse is in the best interest of the patient, but it's not FDA approved.
Right.
But it might still be in the best interest of the patient.
But I think the
liability is still on the surgeon.
Yeah.
Yes.
But I think the biggest issue, probably potentially, is really the patient's concentration.
Yes.
Like,
right.
What did that patient do the night before?
Exactly.
The
Yes.
day before,
I just
that
learned this
day?
from Jazz.
Like,
yes.
So
It's
he was saying that exosomes are dynamic. So PRP is an exosome. It's a signaling molecule.
Yeah. Yep.
And we harness the body's natural ability to heal, and we just concentrate it. And we
Yes.
put it back and we say, here, go. So the concept makes sense.
Yeah, no,
So
it's
and I
absolutely.
think you're actually getting the stuff. So let's say you're getting all that stuff.
Yeah.
He was talking about the fact that there's recent developments in these papers that are coming out showing that exercise 30 minutes before can stimulate
Yes.
increase in stem cell
100%.
production.
I saw that.
100%.
And so, and so that leads you to believe, like, okay, well, then maybe there's ways we can optimize PRP harnessing so
Right.
that when we do it, it should be optimized for that indication. Because maybe if it's low and I do it, but tomorrow it's high, let's do it tomorrow.
Yeah.
Well, then
Don't do
take
it today.
Take
or
that
maybe you
tomorrow.
should be dehydrated, so that it's a larger concentration of platelets that you're going to get on your 30 cc's or 60 cc's.
And stimulating through XR nutrition, through getting the right nutrition will also stimulate that, because if you're in a catabolic state, your body is not producing. If you're in an anabolic state, which that does, exercise does, it revs it primes your system.
Right.
So I tell people, when I do PRP or stem cells, you do nutrition for a week before, and you exercise for 30 minutes before the procedure.
Oh, that's good. Yeah.
I mean, I do tell them to
We
do
should
that.
do that.
And if they don't do it, then I'm still going to do the procedure, but I at least recommend what will optimize them.
Yeah.
And then you layer that with BBAC, for example.
BMAC,
Right.
bone marrow aspirate
marrow,
concentrate. That's where you get stem cells.
That's where you get the stem
That's where I
cells.
shifted to understanding stem cells have a role in my practice.
Oh, 100%.
Is the fact that they come from you, and I'll put them back in you. They come from you, I'll put them back in him. And I'm going
sir.
to put him on these programs to optimize how much his stem cell activity has before I say, I'm going to drill into your hip, suck it out, and then put it here. It's like, that's a lot. If I were going through that, I would want to know,
Well, and the
how is
problem
this best going to work?
and the problem as a patient, as we've seen, it's like my hip hurts way more than
Yeah.
what
So
you
which one? We got
injected.
to do two if your hip hurts. and
Right. We're
shoulder.
drawing
Exactly.
60 cc's, and we're going to put a choke needle into your hip and
Yeah.
suck all these stem
I
cells.
think they still need scaffolds. I don't think I think they may work some of the times, and we just pray to, what do you want to call him? Not Jesus. You don't like Jesus. He created Darwin. I love Darwin
your
too.
God.
Yeah, pray to your own God. How do we
How's that?
make these stem cells
Call
heal?
it whatever you want.
Right.
Call it whatever you want, but I know there's a force there that sometimes allows these things to take and heal.
Yeah. No, absolutely.
And that involves us, but as surgeons we say, put it here, attach it, pull on it. It's strong. I know it's good.
Right.
Let Jesus heal it.
Right.
Or, it's like, I'm going to inject you here and let's just hope it heals.
Yeah.
But I'm not mechanically testing that, and so it is a belief almost.
Sure.
Where you have to believe and have faith in the process.
Yeah.
And so
No, I
that's
agree
why
with
I'm
you.
selling, hey, have faith in this thing that I'm saying is that maybe work, maybe not.
And the technique comes down. You and I've seen it for with BMAC and PRP, put it in the Achilles, put it under the footprint, and then suturing it down. Are you using a suture bridge? Are you using a triple row? Blah, blah, blah.
What is your technique?
What is
to
your
get there that
technique
you
in
find
addition
reliable?
to that? So now you got this great cocktail of biologics that's going to use Jesus' power to heal you, right? And all the optimal optimizing your nutrition, optimizing your biologics, optimizing that footprint.
And use prayer.
Right.
And a little bit of luck. And luck.
Now you're giving me
luck.
flashbacks of
Yeah.
confession. Go say 10 Hail Marys.
Hey man, the more I learn, the more I realize I don't understand.
Well, I think the other,
the farther I go.
thing that I think eventually I can see this in the future is that, as you know, all these factors, some of them live literally milliseconds, and we don't know what the order of the cascade.
Yes.
That's sort of the optimal healing cascade is really. And so I can see something in the future where it could be like a layered, almost like a capsule that has multiple layers. Layer 1 comes off in 1 second, layer 2 comes off in 3 seconds, and so on and so on. And so that it actually delivers what you want it to deliver in the appropriate time frame. So that's where it's going to go. And the technology is there. It's just a matter of how expensive would that be? That would be prohibitive
goodness.
at this point. But the technology is there. We know what the order of the cascade of these things is.
But they have devices, that will be time eluding, right?
Yeah.
Or they'll be like liposomal, so they last longer. And
well, that's how you have to deliver it with liposomes, basically.
They end up being with exosomes.
But you have to build this thing.
Yeah.
So that's where I would see. That's where
how to get it in, how to make it timing in. That's what gets so interesting.
Put
because
the right
device,
little device in there. That would be cool.
It's an unsolved problem still. Is partial thickness, full thickness rotator cuff tears.
Right.
Like we still don't quite understand that process, but I've seen people get better from surgery, so we know surgery is predictable still.
Yeah.
And we know that is the current gold standard for some problems. And sometimes even with small problems that are in between, people can get better from hip and from shoulder, and like these instability things. And we don't, those 20 to 30% of people, you don't really understand why.
Right.
It's probably something that you could understand. We just don't really understand.
So many variables.
The testing. Speaking of testing, you came up with an arthrometer, some way to measure instability in the shoulder. Is that still an active? Is that anything that's used from research? How did you develop that? 'Cause that concept is really cool, like a device.
Yeah,
that
it's
can
like a
measure
KT.
stability.
You're familiar with KT1000
for the ACL.
My idea was to have a KT1000 for the shoulder, and so I came up with a device that I eventually got it published or patented. And so basically, it was like a shell that you can put over the shoulder.
I'm gonna look it up, see if I can
and
find it.
You can translate. And I actually shopped it around. I tried to see if the guy that built the KT1000 was interested, but at the time I didn't realize it was like this little dinky, tiny little factory in San Diego that was like a one-man shop. So it wasn't exactly.
That looks like a knee.
Yeah.
That's a shoulder.
If you're gonna find anything.
It wouldn't be here.
I don't know.
Let me see.
Maybe.
Guanche.
So it measured subluxation, 50-50 translation.
Yeah. So it was really more to get around the idea of, so can you document your post-op recovery?
Right.
Like if you translated, just like with the KT1000. Oh, that's my pictures. Yeah.
Is this it?
I think so. Yeah.
This one?
Yeah.
You see it?
That's part of it. Yeah.
That looks complex.
Yeah.
That looks like it's made for research, Carlos.
Oh yeah.
Well, yeah. So it never really made the prime time.
Yeah.
But
it was
this
too
looks
hard,
effective
too hard
to
to
study
do.
it and to test it and
Right.
isolate.
Yeah.
So this would make sense to use for research. Then.
How long
Yeah, I
how long
think
ago
for
was that? 15? I was going to say 15
yeah.
years ago.
It was when I first came here.
Yeah,
To
yeah.
LA. Yeah.
So, well, now think about 15 years forward, the access that we have to biomechanical testing,
Right.
right? And now we can do,
Yeah.
Well, a lot of it can be modeled now.
Yeah.
Maybe like model things. Like that's kind of what I was saying earlier. Is like maybe there's just different ways to look at those things.
There's a
and
lot,
with
yeah.
new technology.
So, dumb question. To your point that you touched on earlier, is that reverses have a long-term great success, right? That the success is in the numbers, right? But yet at 360, Professor Willow published that the deltoid's going to fail at 12 years approximately.
Really?
deltoid.
Yes. Well, look, 2 years ago, go to whatever, because you're a surgeon, you can log into the 360 account. But he gave a talk that it's actually funny. Shortest thing of his talk was that, to our surprise, the glenoid side works fantastic, but the humeral component is failing at 10 years because with the Grammont principle, we were distalizing and medializing, so overtension of the deltoid and fatigue, and the humeral components were loosening because we weren't getting proper deltoid wrap, which correct me if I'm wrong, and again, I'm just a knucklehead that opens boxes, but to going to where the whole industry is pivoted to a 135 neck shaft angle, to get proper deltoid rep and keep that muscle belly and that soft tissue
So the
envelope.
longevity is going to be better.
That sounds very industry specific. I mean, I think.
Well,
there's-
you're
I think,
tr-
you know,
that's
the
true.
deltoid wrap thing is almost like a.
Well,
kind
that was
like
sort of a coined
concept
phrase
that
from
was-
one of our.
it was-
Yeah, I don't
right.
know.
But those
I
those
think,
were
I think
his
it
words.
has an effect, but we don't know what
I
causes
haven't seen it,
deterioration.
though,
Sarcopenia
honestly,
is what
you
causes
know?
deterioration.
Well, so right. So my brain immediately went to, well, listen, look at the guys.
Boy, Lo said that.
Yes. 2 years ago at the 360 course, he presented it. As a matter of fact, he had a great picture up there where he's internally and
But
externally.
he was saying that there's not enough wrapping, so it will deteriorate if it's too linear,
Yes.
too much tension.
So the 155 was too much.
Well,
yes.
I think that's true.
Yeah.
Maybe.
Distalized, medialized, right?
You
That-
don't use 155 anymore.
No.
Even Clapper switched, right?
Yes, Dr. Clapper switched
It
to
took him like
Although it honestly, it was a little
took
bit
him a
of
hot
learning.
second once the enhanced came out.
I think it was a learning curve, though.
It
right.
would,
'Cause
well,
it's a
think?
different operation.
it's a different operation.
Yeah.
Yes, sir.
I had
But
a
I think
couple
it's
of
a more
instabilities
anatomic
early on.
With the 135.
Yeah.
That makes sense.
Well, then, but again, somebody like you're using.
I've had them too. Even late, like early, late in my adoption of that implant,
Yeah.
because something feels a little different, and like it takes time to understand how that implant works
It
together.
does. It really
Yes.
does.
Yeah.
Yeah. I didn't think so, but it definitely made a difference
Yes.
for a while.
Yeah. That 135 neck shale reduces a little bit easier.
Yeah.
Right. But all your
One thing I learned about that system too is don't over lateralize, because you tend to want to use a more lateral ball, but just the +4 is actually about
plenty.
right.
Yeah.
It's about 6,
Especially
it's-
for women.
absolutely.
Yes.
I only go +4 with
Well,
that.
Peter Chalmers makes a great statement about there are certainly, because of the scapular thoracic, the way females sit, using a Grammont principled, right, forward sort of scapula, a 155 with 0 to 2 millimeters of lateralization is perfect for those osteopenia patients, for small females. But again, the industry, because he was talking about industry products, this swing of the pendulum going to a 135, which goes in line with Dr. Walsh's paper a couple years ago that talks about 135 neck shaft angle with approximately 4 to 6 millimeters of lateralization is probably the sweet spot.
Well, Carlos, what do you think from all of your involvement with industry in terms of making all these transitions from year to year, going from private practice and then going from SCOE, LSU? I mean, you've seen it all. You've done it all. Carlos Guanche is the product. He's a great hip surgeon. He's a great shoulder surgeon. You've seen it.
Well, he's the wise man of,
Pat,
listen.
Pat is stuck with you. But like,
For 20. He put up with me.
what have you seen from like a surgeon's perspective of having to deal with industry? Is that a positive thing? Is there any advice you could give to young surgeons who would just say like, man, that's just like Carlos Guanche, he's got all these patents and he's got royalties, I'm sure. And, it's like, that's what I want to have someday. What do you give advice to the young surgeons listening?
Some of it, I think you have to really be very careful in how you present things to companies. I think I won't tell you who the company was, but I got burned by a company I presented something to them and I had it all, an idea all documented. I had diagrams and I, emailed like a whole email chain. And a couple years later, I was at a meeting and I saw the product. And so I went back to them and talked to them, and I said, here's my product, and this is your product.
Right.
What's going on?
Here's my evidence.
Yeah.
And
Sure looks like my design.
coincidentally,
Yes.
hey.
And so I ended up getting royalties, retroactively because
They were going to do that anyways, I'm sure.
Yeah.
Oh, yeah.
2 years.
High on the list, I'm
We're
sure.
going to get right on that. We'll
The
get you
product
royalties,
had
all right.
been out like 2 years,
Yeah, it's called
so,
interest.
Yeah.
It's called interest now.
Exactly.
Compound interest.
And so, I always tell people, and actually, in fact, one of my last couple of fellow from 2 years ago just texted me about something like that because he's got some ideas, and I said, make sure and everything. Number one, have the company. You bring your own NDA, non-disclosure agreement. You can download one off the internet, easy. Have them sign your non-disclosure agreement, not theirs. Number two, I would make sure and write down everything, the concept, put it in an envelope, mail it to yourself. Don't open the envelope. So you've got documented timing when your idea came to live, and then everything that you present to them, make sure and have at the very top confidential, Carlos A. Guanche MD, date of, presentation or whatever. Everything that you give them, every page has that on it so that, are you going to get burned? Every once in a while you might get burned, but that's one way to, to really, and, I mean, we all think we have the greatest and the best idea ever. And the reality is that most surgeons come up with one really good idea.
It takes a lot to get to
Maybe,
a product. You have a lot of good ideas.
Yeah. Like I've had 100 of them,
Yeah.
for the 2 patents, I've, 5 or 7 or whatever. So just be patient with it. I think it's a matter of just keep innovating, keep thinking like what, like every once in a while I'll kind of think about like, what am I, what's wrong with the shoulder scope? What else can I do? Or hip scope? What can I improve on? That's why I came up with the idea of the endoscopic hamstring a few years ago, and that came from a meeting I was with, I don't know if you know Brian, oh my God, at HSS. He's the head of, so Brian, Brian
guy?
and I, what's that?
Is it Warner?
No. Oh my God.
Russell?
No, Russ Warren.
It'll
is-
come to you. Right?
Yeah. Anyway, Brian,
Yeah, Russ Warren.
he's at HSS. So basically at a meeting, we were talking at a hip meeting, and we were talking about hamstrings. And I said, well, do you think we can probably do it endoscopically? He's like, yeah, we can. I think so. He says, I think I'm going to do one like in the next couple of weeks. And I said, not if I beat you to it. So it was sort of a challenge. Like
People were coming to me early on at Cedars like, oh, you're the sports guy. I'm like,
Yeah.
no, I'm a shoulder guy.
Yeah,
You want me
right.
to fix one of these things.
Yeah.
You have to fillet it. You
Yeah.
got to, go down and pull
Right.
it up. So
Yeah.
that's a big deal
Yeah.
operation. I was like, I knew enough to say I don't want to
Yeah.
do this one.
Well, the endoscopic hamstring looks just like in fact, Steve Snyder, I would, because he would be in our center a lot. And so a couple of times he and I would actually operate on the same day. So he walked in on a couple of my endoscopic hamstrings, and I said, look, Steve, I would turn the scope sideways, said, looks like a rotator cuff, looks like a hamstring, looks like a rotator
He's
cuff.
got to do everything
It's the
sideways for
same guy.
lateral, right?
and I was putting his anchors, the Threvo. So I said, look,
Threvo,
you can
yeah.
even put these in the ass. And they worked,
Ischial tuberosity.
Yeah,
Right.
yeah, exactly.
Well, that
Also known as the ass bone.
Yeah.
but necessity is the mother of invention.
Yes.
Right.
Yeah.
So
I mean, that sounds ripe for product development.
Yeah.
I mean, you had this big, sounds like a pretty big gap for development where there just weren't products or there weren't procedures or
No,
techniques where you're
no.
like, I can just do this. I got
Well,
the
the
scope
hip
and-
stuff, especially.
Yeah.
I worked with Arthrex in the beginning with their tray. They had like a rudimentary tray for all the different, guided, like the guide wires and stuff like that, and they had no clue of how to implement any of these things. So,
Well, most of these deals, they're these consulting agreements, and they say, yeah, if you bring your IP to me, then that's Arthrex IP now, and that's kind of how they do it.
Right.
But that's what most companies do.
Yeah,
You
yeah.
know, if you're a young consultant.
Yeah, you have to be
that's
very
pretty
careful.
standard.
Yeah.
That's pretty standard. So it puts it on you to be careful,
Right.
right? With
Yeah.
your ideas. So you
Yeah.
have to know this is an idea, and this is feedback on the device that I'm giving
Right.
for the company.
Yeah.
So you just have to separate those things.
yeah, and negotiate stuff up front too. Like part of what you can do oftentimes, like for example, on the hip arthroscopy tray set, they have a disposable kit that comes with it, and so you can say, well, I'm going to help you develop this thing, but can I get a piece of the royalties from the disposable kit? So there's different ways around it. You just have to be creative.
Do you think it's still worth going to industry, or do you think it's better to develop independently?
I'm actually working on something.
Do you think it's
right
worth
now.
going to industry to develop your ideas and your
No,
concepts?
I would come to them with as much of a finished product as you absolutely can, because they will, if you bring them something on a napkin, they're going to say, well, it changed dramatically from the napkin thing to where
The
we are
napkin
today.
got folded in half. Look at it; it's not even
Right.
the same thing.
It's a different thing altogether. So you want to
saw a
come to them
napkin?
with a
I didn't see a
finished, like
napkin.
something that you can say,
Yeah.
Yeah.
put this in a shoulder. And so, in fact, right now I'm working. My son actually has a 3D printer at home, and so I'm working on a device to make injections easier. And we're on
We talked
iteration.
about that.
Yeah,
I think that's going to be a big thing.
yeah. So we're on iteration.
I already could use it right now.
That's right.
I get it
Your CMC
for my
arthritis.
carpal tunnel. Yeah, it's like
Yeah.
I need that. I need your device.
Yeah, so we're on iteration
I'll buy one.
23 or 24 now, where he's
Make it right.
printed it on a 3D printer, and so you can. There's so many easy ways to do it nowadays.
Especially
even
with
if you
all
don't.
the PRP coming.
Oh yeah,
Yeah,
exactly.
Stem cell wave. Or, yeah, we need to.
Yeah.
We can't cause hand
Exactly.
arthritis.
Yeah.
So your device is going to help
what a
us all.
great
Yeah.
segue.
Exactly. Yeah.
That's funny.
So do you think it's still worth doing? I mean, do you think
Yeah.
innovation is still driving
Absolutely. 100%.
better outcomes?
Yeah, no doubt. Yeah, I
It
mean,
comes from
I
guys like
can't
you.
imagine like.
And your son one day.
I mean, look at the the differences in the management of. I think probably the most dramatic thing that I've seen in my 30 years has been the anterior total hip. I mean, that is a game changer. I mean, when I was a resident, even when you were a resident, how long would your total hip stay in the hospital?
It was all posterior when I was a resident.
And they would stay in the hospital
Yeah.
3, 4, 5 days.
It was emerging anterior. Yeah, they would
Yeah.
stay in the hospital. And
I mean, when I was a resident, the patients wouldn't even get out of bed for 2 days because they were in such pain.
right.
you
That's
know?
the opposite of what they
And
should
now-
be doing. They
right.
get up and walk the same
And
day.
now they're like
after surgery.
same hour.
Yeah.
like, you
And it's
know?
better. It's not worse. It's better.
Oh, huge. I mean, I've got patients that are teaching yoga, doing jujitsu. I have this guy who's actually, I was just watching him on Instagram. He's doing, he's a performer. He's, what's his name? Ray,
Oh, Darth Maul.
Darth Maul.
Yeah.
So he did a,
He just did one. I saw
did
that.
you see
actually.
that video?
Yes.
He's kicking a freaking
I-
punching bag.
Yes,
He's
I
got
literally
bilateral
thought of
total
you.
hips.
Well, and to go re-engage in the same,
Yes.
do as Darth
Do you
Maul.
have an Instagram?
Yeah.
What's your Instagram?
It's Guanche / hip shoulder
Guanche.
/ or underscore
Oh,
hip.
I'm under the wrong account. Let me get my LA shoulder account. I'm sure I follow you.
Shame on
Oh
you.
yeah, Guanche.
Yeah.
I do. Of course I follow.
Yeah,
you.
you'll see it.
Was this guy on your Instagram?
He's what's his? I think I have a video of him on.
Here, I'll tell you. Let's see.
This is your Instagram.
Yeah.
Guanche hip
Did
shoulder.
I put him on there? Let me
So
see.
you got to get more active on here, Carlos.
I
In
know.
today's world,
I got to do
Whoa.
more.
Crib boss, there you are. I can't look at those. Whatever they send you, you should look at on Instagram.
Ray
You got to
Park.
turn that
Look
off.
at this.
What is
Look
this? This
look
looks
at
crazy.
I am
That
Ray
takes you
Park.
someplace.
Oh, that's him with the
Yeah,
with the double.
I am Ray Park. Look at him.
Here,
up
I can
there.
look him up. Yeah, let me look him up.
And he's got a video that he just did.
I am. Ray.
There you go, Ray Park. Yes,
I am
sir.
Ray Park.
hilarious.
That's one of your patients.
Yep.
He's okay with us talking about.
Yeah,
it. I'm gonna follow
he's
him.
posted stuff about it.
Well, so this guy was Darth Maul.
yeah,
Yes, sir.
Oh, that guy didn't he get chopped in half?
Yes.
he's hilarious.
That's pretty cool. So he's an actual athlete.
Oh, this guy is.
Yeah, yeah.
Oh, there he is.
Freaking
Yeah,
See
he-
that, Pat?
Yeah,
And
yeah.
he did. He just
that's pretty
posted something
epic.
this last week.
Yes, he
where
did
he was
last week.
kicking a bag.
Yes.
Is he still doing stuff like this? Like for?
Oh yeah, look at
And you did his hip, what, 10 years ago?
yeah.
Oh, there you go.
Look,
Yeah, I got it.
yeah, that's it.
You did total hip.
Yeah, he had horrible hip.
These are the guys
From all
that
those years of martial
they're
arts
gonna
and
keep doing this.
gymnastics.
Yeah, his other hip is not great either, but
Looks pretty mobile on this one.
I know, pretty
I
amazing.
think I'd tell my friend Greg Farr to get a total hip.
He was
from-
doing like
from
flips.
Guanche.
He was doing flips. Like
Yeah, that guy's
6 weeks out.
Man, wow.
Well, we don't need anybody telling you how great you are. How great you are. Your patients know how great you are. They all love you. I know you got to go. You have other engagements to get to tonight, but man, it's been so awesome having
It's
you.
been great.
I wish I could spend more time
Yeah.
learning what's inside.
We're going to
your
have to
brain.
have an episode 2.
You've got to do that. I didn't even hear any old good stories, so I think we have to do another one. We
Oh,
gotta
he's
have you
got
back.
he's got some great resident stories from Miami that I have heard a couple
Yeah,
times.
I don't know if we can
that-
talk about those on here.
Right, right. So,
Cocaine Cowboys.
Oh boy,
Yeah.
is that why they wrote that movie?
My favorite
Miami
was
in the
the.
80s.
Have you ever seen the little cocaine things that they would swallow?
Oh, that's like the
little balloons.
Yeah,
Yeah,
yeah.
The mules.
The mules
did that
swallow.
Right.
to get
so,
through.
So when I was a 4th-year medical student at Miami, I got a call. A guy came in on a flight from Cali, Colombia. Or no, but he was from Bogota.
Suspicious.
Bogota to
Suspicious.
Miami. He had a seizure on the plane, and so the guy fessed up. He said, "I swallowed balloons." We get a KUB on the guy. There's probably 30 or 40 little,
I swallowed one. No.
and each one of these things is almost. It's I think they said it was
it's about a
5
gram,
or-
isn't it?
No, it's more.
Oh.
It's 4 or 5 grams of pure coke, and there was 2 condoms. It was a condom and a condom, but I guess one of them had a little pinhole. So the guy had a seizure, and he
Somebody was
fessed
trying
up.
to get pregnant.
So we take him to the OR, and I'm the intern on the service. So he's in the lithotomy position. I'm down there with a basin catching, and
All the balloons coming out.
yes, and the resident. The funniest thing is the chief resident. So we have 2.
Hey,
you
I
have
said
to-
there was 30 balloons. Where's that 20?
well, that's the joke. So listen to this. Funny you should say that. So there's two Miami cops, city of Miami cops, waiting. They're dressed in their bunny suits. They're waiting to grab the evidence. And the guy who's doing the surgeries, he's actually a Colombian resident of all things.
people.
Yeah.
Right.
So we do a big laparotomy. He's squeezing these things out, and I'm catching them. And after like 4 or 5, he goes, "Okay, boys, that's it." and the cops are like,
We saw that X-ray.
The guy had like, I
Dig a
forget,
little deeper back there.
I think he had like 35 or 37.
moly.
They said it was, and this was 1987 or
He
something
survived
like that.
for another drug mule.
I was going to say, did he
no,
survive?
They said this was like $1 million of cocaine that this guy was carrying. They had given him $500.
Wow.
Yeah. And he could have died.
And a free plane ticket.
And
Yeah.
the ticket.
Plane ticket to
Unbelievable.
Miami.
Isn't that crazy?
Yeah.
Wow.
It's
pretty
wild.
wild.
That is
And he had to
crazy.
get cut open.
Yeah.
Well, that was a good story to end on, man.
I don't know if you're going to weave it into the...
Oh, no, of course. It's going to be in there for sure. Well, this is the last edition of the 6th episode of the LA Shoulder Podcast. Until the
Awesome.
next time, great having you, man.
Awesome.
All right, dude.
Thanks for
Good
having
one.
me.
Thanks to have you, Pat.
Thank you.
Thanks for having me.
Thank you, guys.
That's all, folks.
Love it.